Good evening, respected chairpersons, respected speakers, dignitaries, and audience. I welcome you all to a complete academic extravaganza under the aegis of AOGD and ICOG. Today, we are discussing a very important and critical subject. Today, we are discussing genital tuberculosis and how we treat it. I invite our chairperson for today, Dr. Mala Srivastav, President AOGD 2020-21. She's Senior Consultant and Professor GRIPMA, Gynae Endoscopic and Robotic Surgeon at Sir Ganga Ram Hospital, to say a few words.
Good evening, everybody. I bring greetings from AOGD. It's my pleasure and privilege to welcome the galaxy of senior members of a fraternity from FOXI, ICOG, IAGE, IMS, and we have galaxy of stars, presidents and past presidents to this evening. I congratulate Dr. Kuldeep Jain and Dr. Sonia Malik ma'am for organizing such an elaborate academic meet on the saga of genital tuberculosis, how I treat. I'm very happy to welcome our chief guest, Dr. Alpesh Gandhi, our FOXI president. Sir, entire country is vibrating with academic activities and virtual learning, the lead given by you. I'm privileged to welcome our guest of honor, Dr. Mandakini May, Chairperson ICOG. Madam has always guided us in all the academic ventures. I'm pleased to welcome our guest of honor, Dr. Parag Biniwala, who has always helped us in all activities that we do. I'm delighted to welcome our guest of honor, Dr. Neerja Batla. Madam has always helped us when we are in trouble. I'm privileged to welcome our star speakers of the day, Dr. Nandita Parshetkar, our immediate past president FOXI, a very charming and very encouraging personality. I'm happy to welcome Dr. Narendra Malhotra, our past president of FOXI. Sir has always rendered pearls of wisdom for the members of FOXI. I welcome Dr. Sunita Tanulwalkar, President IAG. Madam has a charismatic personality with keen endeavor to share her knowledge with everyone. It's a proud privilege to welcome Dr. Kaval Gujral. Madam is a chairperson, head of department, Institute of Obs and Gynae, Sir Ganga Ram Hospital. Madam has been past president of Nachi Delhi branch. She is the guiding force of all the academic activities that we are doing on behalf of AOGD. I'm happy to welcome Dr. J.B. Sharma. Sir is a professor of All India Institute of Medical Sciences. In the end, I again congratulate Dr. Kuldeep Jain and Madam Sonia Madam, who have knitted and integrated this scientific program. And I'm sure all the viewers will have highly benefited from this evening proceedings. Thanks to all of you. Over to you.
Thank you, ma'am. I now invite the Secretary of AOGD, Dr. Mamta Dagar. Ma'am is Senior Consultant, Sir Ganga Ram Hospital, to introduce our chief guest for today.
Yes. Good evening, everyone. Am I audible?
Yes,
Yes, yeah. Good evening, everyone. On behalf of AOGD, I once again welcome you all to this webinar on the saga of genital tuberculosis, how to treat. And we have with us, as has been introduced by Dr. Mala Srivastav, very esteemed moderators and speakers today for the session. And I am happy to share that our chief guest, Dr. Alpesh Gandhi, is with us today. Dr. Alpesh Gandhi, sir, do not require any formal introduction, but in fact, it is my honor to give a formal introduction of sir. Dr. Alpesh Gandhi is President FOXI 2020. He has been the Vice President FOXI 2013. He is the Governing Council member of ICOG FOXI 2016-17 and Chairperson of Practical Obstacle Committee FOXI 2009-2011. Vice President in Gestosis India chapter. He has been the convener of most successful AICOG 2017 Ahmedabad and past treasurer SOGOG Society of Obs and Gynae Gujarat State. He has authored many books and has several awards and publications to his credit. His book on principles of critical care in obstetric is available in more than 5,000 word-renowned medical libraries, published by an international publisher and translated in Chinese and Spanish language. And also he has been awarded by RCOG, Honorary FRCOG. He's the founder admin, the biggest social networking of Foxians on Facebook. And he has several numerous, laurels to his credit. He has been, in fact, a person of repute, and it is under his dynamic leadership and vision that Foxy is sailing, the ship of the Foxy is sailing through these difficult times of Corona crisis. And we salute you, sir. Over to you, sir, Dr. Alpesh Gandhi, sir.
Before Dr. Alpesh speaks, it is my humble endeavor to just do a virtual inauguration of this seminar. So, Ankita, can you please play the virtual inaugural?
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापं सन्ध्यादीपनमोऽस्तुते ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः आरोग्यं देहि पुत्रांश मतिं स्वच्छां हि मे सदा रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् यस्य तिष्ठे गृहे दीपः तस्य नास्ति दरिद्रता शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम्
May we request Dr. Alpesh to say a few words to us today?
Thank you very much. A very good evening to all of you. At the outset, I am thankful to AOGD, President Dr. Mala Srivastav, Secretary Dr. Mamta, Madam Sonia Malik, and Dr. Kuldeep for inviting me as the chief guest and to inaugurate this webinar. Delhi society, AOGD is very vibrant society. I must congratulate AOGD for continuing great academic during this difficult time of pandemic. I am thankful to Dr. Mamta for the kind introduction. I must congratulate AOGD for selecting a very useful topic, as it is mentioned, very critical topic, difficult topic, which is relatively discussed less, but very useful and important topic. The incidence of female genital tuberculosis varies from 3 to 16% in India, and incidence is different in different parts of our country. Genital tuberculosis is a major causative factor for the severe tubal disease requiring sometimes assisted reproductive technique in developing countries like us. Sometimes it may require a multidisciplinary approach with a gynecologist, sonologist, pathologist, microbiologist, infertility specialist, endoscopic surgeon, and I am happy to see all the experts, a galaxy of faculties present today. I hope this webinar will enlighten all of us, all the viewers, with very good discussion and take-home message. I wish a grand success to the webinar. I wish all of you happy learning. Stay safe. Thank you very much. I would not like to take much time, and I hand over mic to Dr. Mamta. Dr. Sonia Malik.
Thank you, sir.
Thank you. Thank you, Dr.
I welcome.
Alpesh, for your kind words and presence. Your presence is actually very encouraging for all of us. And for that, because you are so busy in inaugurating all webinars, so I am really thankful to you for giving your encouraging words to this AOGD meet. So thank you very much for joining. Ankita,
Thank
over
you,
to
sir.
you.
I welcome our moderators for today, Dr. Sonia Malik. Ma'am is Director and HOD at Southend Infertility and IVF. Ma'am is past President, Indian Fertility Society, past President, Indian Menopause Society. Ma'am is recipient of IMA Kanak Goyal Award 2007, IMA Lifetime of Achievement Award 2015-2019. Dr. Sonia Malik.
Good afternoon to all of you. Before I take over, may I just ask Dr. Kuldeep to talk to you a little about the concept of this webinar. And this is actually going to be a series, and he shall be introducing the webinars to you. Dr. Kuldeep, can you please take on, and then I shall take over from you.
Yeah. Thank you, Dr. Sonia. It is indeed a pleasure to be connecting with so many faculty and audience on this very important series, which we have termed as Key Opinion Leaders series. As you know that we are always having a lot of difficulties, debate and controversies in our daily routine practice when it comes to reproductive problem management. So all our practices actually, they are based on the evidence based as well as on our own experience, and we always try to combine the evidence based as well as the practical experience which we gather over the period to solve and help our patients' problem. When it comes to the difficult subject which are always in debate and controversy, like genital tuberculosis is one of them. Then endometriosis is another subject which is very difficult to diagnose, treat and manage. And then it comes when the patient gets pregnant, then recurrent pregnancy loss. So in this series, actually what we are planning to bring to you, in spite of having so many recommendations, so many guidelines, but when it comes to the actual clinical scenario, we are just looking to our seniors and teachers that how they have been treating these problems and giving the success stories years after years. So the concept of this Key Opinion Leaders series is we have invited a galaxy of experts who are institutions in their own to share their knowledge, their experience in conjunction with evidence-based medicine to solve the dilemmas, problems, and questions which everyone is facing in their day-to-day life. So today is we have taken the genital tuberculosis, which is actually, if you see, we are having more problems than solutions when it comes to the management and diagnosis of genital tuberculosis. And today we are having the galaxy of experts who are real key opinion leaders in India. And what we are looking here, we will be throwing a few questions which are actually coming from our audience to them, and then asking them how they treat or they solve these problems in their routine practice. So this is the concept we are having, first one is genital tuberculosis, second one will be endometriosis, which is on 26th July, and the last one on recurrent pregnancy loss, that is on 8th August. So please block your dates. We will be having again in next two series the actual key opinion leaders who have been working for years together to get the knowledge, and they will be sharing their experience on these subjects. So I hope this series will be very helpful in your day-to-day practice. Over to Dr. Sonia to proceed further in the program.
Thank you, Dr. Kuldeep. So without wasting any more time, let me just start sharing my screen, and we shall get going with this. Well, as has been told earlier, we are talking about a subject which is with us for time immemorial. And I know now that Corona has beaten it, we are more bothered about Corona. But nevertheless, if you look at the data that you have from WHO, TB still ranks amongst the top 5 killers of women in the adult age of, in the age group of 20 to 59 years. And we know that there are lots of women dying with tuberculosis. And despite all the global efforts to contain it, we still have a lot of burden of tuberculosis in this country. How important it is to study tuberculosis in women is because it has biological differences in women. There is a delay and difficulty in the detection of the disease. Many women are non-compliant because they think they are affected. If it was their husband, it would have been a different issue. And then, of course, there is a lot of stigma about the disease. Hence, it is difficult to understand the disease more in a woman. However, we all have to understand that it can affect all women at all ages, be it the adolescent girl or be it the geriatric postmenopausal women. But of course, today we are concerned with the reproductive age woman, who is pregnant and who is non-pregnant. So let us today get together and see how we are going to decipher this disease in patients who are suffering from it at this age group. And of course, we know that genital tuberculosis forms a huge part of
now it will disappear.
Pulmonary tuberculosis.
Your office is in the city.
Dr. Alpesh also said there is a variation in the incidence that has
been
in
the farm. I think that
in the country. Basically, not only because of the ethnic difference. Of course, a Bimaru state will have more of genital tuberculosis than another one, but also because of the diagnostic tests that have been used to detect it. We shall learn about it as we go ahead. And of course, that there is also a report which was published way back in 1990 by Dr. Tripathi from Bhubaneswar, and she states that in about 25% of pulmonary tuberculosis, there is the presence of genital tuberculosis along with it. So that's a huge number of patients who are suffering from genital tuberculosis in the country. And what is the problem that the gynecologists face? What is the dilemma that we face? It is when to suspect the disease, how to diagnose it, what are the relevant tests, and what is the effect on pregnancy, fertility, and lactation. So these are some of the common questions that we come across, and these are some things that we don't know how to answer. And so with that, today I have with me my colleagues, my friends, and experts who have always been the leading lights, the beacon lights of this country. Let them just tell us how they are going to go ahead and do this. So with me, we are today going to have all of them speak on the different aspects of tuberculosis. And the first speaker that I have with me is Dr. J.B. Sharma. We all know he's an academician. He's a professor in the Department of Obs and Gynae at All India Institute. He has more than 270 publications and index and non-index journals, and he has authored so many books of obstetrics and midwifery. And he has been involved in research projects. Like I said, he's a true academician, and now he is also the reference point for tuberculosis, having first of all participated in the Index TB guideline that the Government of India has released in 2016. And along with that, he's constantly upgrading those guidelines. So we want him, first of all, we want him today to talk about the clinical diagnosis of tuberculosis. And his topic for today is therefore the clinical diagnosis of genital tuberculosis in his practice, because he's seen a huge number of patients in All India Institute and Maulana Azad before that. So we want to understand from him his experience. And my questions to him are, what is the definition of genital tuberculosis? What is a definitive case and what is a presumptive case of tuberculosis? Are there any pathognomonic signs of genital tuberculosis? Are there any definite signs which are going to really clinch the diagnosis? Is there anything like that? What are the suspicious signs of tuberculosis, and there is a suspicion and it makes you investigate the patient. So what are those suspicions? And what is the importance of past and family history in these patients? And how long do you treat these? So these are some of the things that we are going to ask him to answer for us. And with that, I think I will ask Ankita to please put up his slides now for him. Please share his slides. I will stop sharing mine.
Can you hear me? Can
Yes,
you hear
we can.
me?
Yes, we can.
Okay.
Yes.
So thanks a lot, madam, for inviting me at such a beautiful conference you are organizing, including President Head Kam and sort of Sonia Malik, Kuldeep Jain, and all the galaxy. So I'm thankful for the kind introduction. Yeah, we can go with the slides, please. Next, please. Yeah. So already this has been highlighted by Dr. Sonia Malik, that the intensity of problem, how many cases are there in the world. Next, please. So basically, as madam has asked me, that pulmonary tuberculosis remains the commonest tuberculosis, but extrapulmonary is becoming important, and genital tuberculosis comes important category of extragenital tuberculosis. It causes almost 10% cases of infertility in India. Incidence is higher in AIMS, like 16%, because we get referrals from Bihar and other areas. Next, please. Next slide. Okay. So usually genital tuberculosis almost always occurs secondary to pulmonary or extrapulmonary tuberculosis, like from abdomen. It can come from lymph node, and also we have to be very careful that when we are examining a patient of genital tuberculosis, do have a good look in these patients. I have seen at least 3 or 4. I had a girl with tuberculosis with TO mass, and I suspected she was totally virgin girl, and she had TO mass, and I didn't know how to go about taking a biopsy or FNAC from that. And then when we carefully admitted her, and when we carefully examined, there was a lymph node in her neck, and we took a sample from there, and it confirmed to be tuberculosis. Another girl, unmarried girl, she had a sinus on her left knee, so we could diagnose. So we have to keep our eyes and mind and brain open all the time. There may be some sign hiding somewhere in these patients. Okay, and as Dr. Madam Sonia Malik had highlighted, what I'm finding, madam, in many patients, when you take detailed history of these girls, when they are coming to you for infertility, if you ask them, okay, in the past, any family history in the family of tuberculosis, and many times I'm finding almost 15 to 20% of my patients, they say when she was adolescent girl, like 14 or 15-year-old, she looked after her dying father, grandfather, grandmother who died of pulmonary TB. And then I realized that usually these the adolescent girls in the house, they look after their elderly grandparents and all. I wish the boys would look after them, because the girls, if they get tuberculosis, it's more damaging to them. And that's I'm finding that history. But unless you specifically ask, they will not tell this history to you. And many times they hide it from their husband also. So that history is very important. You ask them in confidence that I won't tell your husband. So then they come out that she herself had TB, her family had TB, and she got the treatment. So that can help you. And in the order of frequency, we know that genital, like fallopian tubes, are involved in almost 90 to 100% cases, while uterus in about 70% cases. And many patients can be asymptomatic. So this is what I want to highlight, that up to 12% patient may be asymptomatic. So don't wait for the symptoms to happen, but that there can be fever, loss of weight. These can be vague symptoms, may not be there in all the cases. But then menstrual dysfunction, initially tuberculosis causes, basically lesions like ulcerative lesions. Then patient will have menorrhagia. But later on, the tuberculosis will eat away the endometrium. So patient will have hypomenorrhea and oligomenorrhea and ultimately amenorrhea, which may not be amenable to treatment also. I'm seeing an unmarried girl belonging to very high socioeconomic status. In fact, yesterday only this patient came, after completion came. She has been made 27-year-old MBA girl from a very top family. I mean, in fact, her real uncle is a consultant gynae in UK, and so she has it, and unfortunately, in spite of ATT, she's proven. I did histoscopy endometrial biopsy on her. It's histopath epithelioid granuloma. So those cases are very bad, and unfortunately, they can be permanent deficit in them. So and then infertility is a very common finding in them. Some patients can have mass, but this mass is unlikely of ovarian cyst and all. It's vague mass. Then they can have abdominal and pelvic pain. Acute abdomen is usually secondary because of secondary infection and abnormal vaginal discharge. Next, please. Similarly, there may not be any signs in genital tuberculosis. So 12% patient may not have. So don't wait for the signs to happen. But many patients may have some constitutional symptoms like fever, lymphadenopathy, some crepes on chest on careful examination. And on abdominal examination, they may have a bit vague mass, not very definite usually. And they may have ascites and doughy feel of the abdomen. And on vaginal examination, there may be uterine enlargement, but usually that may be because of pyometra, which is secondary to, not because of directly tuberculosis, but secondary infection. And then adnexal masses and induration is common. Tuberoid masses, fullness and tenderness in the pouch of Douglas. But in our study, we found it, adnexal masses in about 18 to 20% cases of total FGTB patients. And rarely they can have hypertrophic lesions, ulcerative lesions of cervix, vagina, vulva. In our study of about 300 patients of tuberculosis, I had 6 patients of cervical tuberculosis. In 4, we made the diagnosis of cervical carcinoma, took biopsy also. But the young age of the patient, I went in favor of tuberculosis and ultimately histopath confirmed the diagnosis. So very important, I already highlighted that family history and history in close family member, past history, as I said, is important. And then do a careful examination, as I said in those examples, bones, joints, skin, lymph node, especially in unmarried girls. So you will find some cause. I have even seen a case of unmarried girl, no sexual history, and she had a rectovaginal fistula. And when we took a small biopsy from there, it turned out to be tuberculosis. And while I was waiting to repair the fistula, I gave her ATT. Have a guess, on ATT, fistula healed itself. No need of surgery. So please don't jump for the surgery. Let me, first give them ATT and then they will. So the test will depend on the site of tuberculosis and its clinical presentation. Next, please. And next slide. Yeah. So investigation of genital TB, these complete blood count are not very useful, but some raised ESR, anemia, leukocytosis, lymphocytosis can give some clue, but they are not diagnostic. X-ray test is useful to confirm or exclude X-rated tuberculosis, and many times in about 8 to 10% cases, you can find some old lesions of tuberculosis. Mentox test is not have limited utility, but if a mentox of more than 10 millimeter can help you a little bit in these patients, and if it's a negative test, it's more useful. And serological tests have been banned; we don't do them anymore. Then endometrial, but this IGRA test and all, or gamma interferon may be of some use in some patients. Endometrial sampling is important. What we do in AIMS, we take with number 4 Carmen's cannula, but you can take with endometrial biopsy period, you can take with pill also. But Carmen cannula is very cheap, just 10 rupees one cannula. So you can take and divide the sample into 4 or 5 parts. And what I want to highlight, we were doing the test in first our 80 patients, all cases were coming negative for gene expert. And then we did, so what was happening, blood was mixing with that endometrial sample. And then when we started separating it, we started homogenizing it. So send the white tissue for gene expert. Then we started picking up the cases. So blood is the inhibitory of factor for gene expert, negative. So when we are taking the sample divided into 4 or 5 parts, one part is to be sent in saline for AFB microscopy, then AFB culture, which you can do bacterial culture, MGIT culture. But in this case, I strongly advise you to, you make friendly with one consultant microbiologist and one consultant histopathologist who has special interest in tuberculosis, because you won't get a typical, in this case, pickup rate will increase if the person is experienced and you have a good rapport with that person, then your pickup rate almost doubles. Okay, so instead of 4 to 5%, you may go up to 10%. Okay, and similarly, histopath also many times, because every month the periods are, patients have menstruation, so endometrium is set off. So typical epithelial granuloma may not have time to be formed. So, but sometimes in the localized lymphocytosis can give you a clue. So like we have Dr. Pradeep Venkat, Dr. Venkat Iyer in AIMS, so he can pick up those cases which are missed by other pathologists. So this is useful in those cases. And then one sample we send for PCR. Though PCR is controversial, I'll discuss that, but we still do it. But again, that has to be done by accredited lab with which you have good rapport. And don't depend on PCR. Alone on the basis of PCR, neither we diagnose tuberculosis nor we start treatment. But that can give you some clue to do more tests. So then we do histopath in formalin for epithelial granuloma, and gene expert, of course, we do. So in saline sample we send for AFP microscopy, culture, gene expert, and PCR, and in formalin we send for epithelial granuloma. Next, please. And next, yeah. So this PCR test, I mean, basically it's controversial, and Government of India in index taking guideline, they refuse to take it, but still we are doing it, because what happens if you are depending on the gold standard AFB microscopy culture or gene expert, we have just finished the study, it's accepted in European journal, will come soon. So we found only about, like, out of 167 cases of genital tuberculosis on composite reference standard. I will tell you what that is. So only in about 31 patients gene expert was positive. So almost just about 20 to 25%. But when it was positive, then you can take it as good as AFB microscopic culture. So that means in fact the editor of the journal especially asked me to write these lines, that when gene expert is positive, I mean, it has very high specificity, almost 100% specificity. But when it is negative, patient may still have tuberculosis. So just like in AFB microscopy culture and all. But I mean, if any patient has got AFB microscopy positive, AFB culture positive, gene expert positive, the straightway definite patients of tuberculosis, definite tuberculosis, no need to do any more tests, and you can straightway start them treatment. Similarly, epithelial granuloma on histopath, straightway you can start. But only problem is that if you depend on these tests, they are very good, they are gold standard, but you will pick up only 25 to 30% cases, you are missing 70% cases. And if you depend on PCR may become positive in about 200% cases. So then that means you will be treating another 100% extra patients. So what we do in AMD, that if the patient is positive on any of these gold standard tests, we take it a definite TB and start them ATT. But if the patient has got only PCR positive, we don't start the treatment or label the patient as tuberculosis, but then we do other tests, because these patients have infertility also. So we tend to do ultrasound, and in ultrasound also then you make a good rapport with the person, like Dr. Sophrana can pick up many cases. So like that, any ultrasonologist, or you can yourself, like Dr. Sonia Malik is a very good ultrasonologist. So you can found sometimes when very tiny, like thin endometrium, breaks in the endometrium lining, some fluid in the endometrium, some fluid in the pouch of Douglas, some encephalitis. So those vague findings can be there. So positive PCR with those findings for TO mass on ultrasound, on CT or MRI or PET, any of these. I'm not recommending that you need to do these tests. Please don't do these tests in patients who don't have TO masses. But in case of tuberculosis TO masses, they are very useful. You can do CT, MRI, or even good ultrasound, 3D, 4D. Person who is experienced in that, they can pick up more cases. So positive PCR with any radiological imaging also can be, that will be a probable tuberculosis. You can't say definite tuberculosis, probable tuberculosis, and you can start it on that basis. Otherwise, what we are doing in the end, I mean, those patients who are negative by all these, but only PCR positive, then we tend to do laparoscopy, cystoscopy on them, because which is part of, it's not unethical to do, because they are infertility patient and they have been usually for 5-6 years. I mean, they have been infertile, so we can give them this sorry. Oh, sorry, can I have slide back again? I think I pressed something. Sorry, some problem. Can I have slides back? And
Sana?
Sorry, can I have slides back? Something happened.
Sana,
so basic.
Sana, can you? Yeah.
So basically, then we do laparoscopy and histoscopy on these patients, which you will doing anyway. I mean, they must be doing laparoscopy in these patients that they require because of their infertility. And then on laparoscopy, there are definite finding of tuberculosis and there are probable finding of tuberculosis, so there are negative finding of tuberculosis. Can I have the slides back, Sana? Okay. So in case of definite tuberculosis, there are only three evidence of definite tuberculosis on laparoscopy, and these are cages nodules, which are very specific of tuberculosis, beaded tubes, which are again very specific of tuberculosis, and tubercles. So these three findings we take, again, they can be, I mean, they're not absolutely, this thing. So, but they can be taken as a case of tuberculosis. And then we have probable findings of tuberculosis, which can be, so probable finding of tuberculosis.
Okay, sorry, slide number 44. Okay. Slide number 44, 45.
Okay, sorry, yeah. So we can, yeah. Okay. Next, please, next, yeah. Okay, next. Okay, so this is the AFB microscopy already shown. That was gene expert machine. This is AFB microscopy. Dr. Sonia Malik has already shown it. Next, please. Next slide. Okay, that is the Gene Expert machine. It's available in almost all government hospitals free of cost, so you can get your testing done for your patient even from private hospital. Next, please. Okay, and this is a Gene Expert paper we published. Next, please. But again, I said the 20 HSG usually we avoid doing in a case of tuberculosis. But suppose HSG has been done already because of without suspicion of tuberculosis, then sometimes we can have good finding but advanced cases. Next, please. So this is a very advanced case where you can see that endometrium is totally shrunken cavity and the tubes look like a dry tree branch. Next, please. Okay. So laparoscopy, I told you that direct visualization is a most reliable tool. Next, please. And you can see tubal, ovarian, and peritoneal disease. These are the various findings which you can say. Next, please. Next, yeah. So tubercles, cages, nodule, tubo-ovarian mass, hydrosalpinx, tubal blockage, abdominal, pelvic, adhesion. And I will be showing some slides also. But I said you the definite finding will be tubercles, cages, nodules, and beaded tubes. Rest others like tubo-ovarian mass, hydrosalpinx, pyosalpinx, tubal blockage, and abdominal, pelvic, peripatetic adhesion, etc. They are probable tuberculosis. But like infertility patient with positive PCR, with these findings, then we can take it as a probable tuberculosis and we can start treatment. Next, please. Okay, and then it can masquerade like ovarian cancer in some time, so that laparoscopy can help in that also. And if you by chance you have opened the abdomen for like ovarian cancer suspecting, and then it turns out to be tuberculosis, then please don't go ahead with surgery. You can stop there, just take biopsy and give full ATT to the patient. Because trying to do TH, BSO in these patients can be really difficult and you can injure the bowel in these patients. So avoid doing that. Next, please. Yeah. Next, please. So these are other studies which we did. Next, please. I will be showing you some slides. Next. Okay. Okay.
I think,
Again,
Dr. Sharma, these are slides which the other speakers will be talking
okay,
about.
yeah, so we can skip them
So just
quickly.
sum it
Yeah,
up at the end. Yeah.
Can we quickly pass on the slides, please? Yeah, so just quickly, next, please. So you can see that, yeah, this is the typical cages nodule. That's a definite finding of tuberculosis. Next, please. Next. So quickly, can you, yeah, various adhesions. Next, please, can be there. So these are perihepatic adhesions. Next, please. So quickly, if you can just show the slides. Yeah, next, these are the adhesions, various slides. These are the beaded tube. These are the cages nodule. They're very definite of tuberculosis. Hydrosalpinx, so ये probable finding. Next, please.
Camera नहीं.
Again, cages. These are tubercles, very specific. Next, please. Yeah, again, cages nodule and adhesion. Next, please. Again, hydrosalpinx. Next, please. Probable finding. This is basically frozen pelvis, and there is a cages nodule. So definite tuberculosis. Next, please. Okay, again, tuberculosis may be associated with endometriosis also. Please don't, usually they are, again, they are same. Next, please. So this was tuberculosis with endometriosis confirmed case. Next, please. This is angry looking uterus and fallopian tubes. Again, next, please. Probable finding. In this case, you can see saggy areas on the uterus and some tubercles. Next, please. Next, yeah. This is the basically Fitch-Curtis syndrome or hanging gallbladder sign. So you can see the liver adherent to abdominal wall and the gallbladder is hanged up. Next, please. Very specific, 40% cases. These are the cages nodule, very definite of tuberculosis and hanging gallbladder sign. Next, please. Next. Yeah. This is the, I developed this sign, blue python sign, in which the fallopian tube becomes like a blue python on dilatation. And later on, the delayed spill is there. So the delayed spill and distended fallopian tube is a sign of tuberculosis. Next, please. Yeah, again, this is the, kissing fallopian tube sign. Both fallopian tube got fused to each other because of and there is a cages nodule there. So it's definite case of tuberculosis advanced. Next, please. Okay. Yeah, again, this is ascending colonic adhesion, which I found in this patient. Lower 2/3, upper 1/3 junction. Next, please. Quickly, if you can, yeah, again, you can see that cages nodule, frozen pelvis. Next, please. Okay. Again, next, please. So the two can, yeah, again, yeah, just keep on flipping the slides.
I think
various types of adhesion. Yeah, because there will be separate. Very quickly, if you can just flip through.
Yeah, Dr. Sharma, because Dr. Nandita has to leave at 6 o'clock.
Okay. No, I'll finish in 3-4 minutes. I'll finish in 3-4 minutes, man. Just start.
Yeah.
If you can quickly, yeah, slide, because I want to show that. Yeah, next, please. Next. Okay. Yeah, next. Okay. Yeah. Okay. This is the basically ascending colon get adherent and the parachute sign. So you can injure if you put the laparoscope there. Second port, so that's important. Don't put the second port on the right side, you can injure the bowel. Next, please. Next, please. Yeah. Okay. Next, please. Next. Okay. Next now. Okay. Next. Yeah. Okay. Next. Okay. This is, yeah. So please just 1 or 2 minutes here. So this is the flow chart algorithm for that. If you can just enlarge it a bit. So whenever a patient comes to you, though I already highlighted in my lecture, patient comes to you. So after taking a good history from that patient, Dr. Sonia Malik was asking me, yes, history of tuberculosis in the family, past history of tuberculosis in the patient, or like if she looked after some family member, ATT in the family, then his patient is having oligomenorrhea, hypomenorrhea, or recent change that is goes in favor, or patient has vague symptoms like constitutional symptoms, fever, malaise, etc. So they will guide you, and then ultimately you have to do endometrial sampling on these patients. And this endometrial sample, I said you sent in 5 parts, and then you do AFP microscopy, AFP culture, gene expert, histopath, and this PCR. If AFP microscopy, culture, or gene expert are positive, definite TB, start ATT. If histopath positive, definite TB, start ATT. If only PCR positive, then you do, if the patient has got some TO mass or some other kind, you can do a good ultrasound scan or CT on them. And if you find TO mass on that, then so infertility patient with positive PCR, with the radiology finding, probable or possible TB can start ATT. But negative, then you do laparoscopy, histoscopy on these patients. And on laparoscopy, if you have definite finding, then you say definite tuberculosis, start ATT. If you have possible finding or probable finding, then it's a probable finding of TB, and then you can still start treatment. But if only PCR positive, the rest everything is negative, ultrasound is negative, and laparoscopy, histoscopy are also negative, then we label it as a negative tuberculosis and don't start ATT only on the basis of PCR. So this is the final algorithm which Government of India accepted. So they did not want to, they are not interested in doing PCR. But as a clinician, I think we can't just avoid doing PCR, but only on the basis of PCR, please don't give them ATT or don't start the treatment. And just my last 1 minute, can you show the slide of treatment, please? Okay, so this category actually has been stopped now by government now. So only basically there is only one category. We don't use the category 1 and 2 anymore. But I just want to highlight that now that it has changed. So we have to give 4 drugs. Isoniazid, rifampicin, pyrazinamide, ethambutol are given daily for first 2 months. You can give and you can refer the patients to government dot center. They will get free of cost drug, and the reporting will also be done by them. And so otherwise you can write like AKT4 for 2 months daily, and then AKT3 for next 4 months, or that means RHE. So you don't give pyrazinamide after 2 months. So rifampicin, isoniazid, pyrazinamide, ethambutol for 2 months, rifampicin, isoniazid, and ethambutol for next 4 months. Total 6 months therapy is given. We published a RCT 6 months versus 9 months, and the results were equally good. That published in European Journal of TB RCT, and from that it is now universally accepted all over the world. WHO as well as the National Tuberculosis Elimination Program of India, they both say that we have to do treatment only for 6 months. And that is what we do. And rarely a patient can be, we published 6 cases of MDR tuberculosis also. So though it's very difficult to pick up TBR, but these 4 patients were secondary MDR. Like they had like pulmonary TB MDR with TO mass, or lymph node confirmed with TO mass, and 2 patients we had only MDR TB.
Dr. JV,
it's over.
Please, because we will discuss. Yeah,
So,
we will be discussing everything in detail at the end of the program.
Okay, fine. My lecture is over. So, just want to highlight the last 20 seconds. So, in that case, you give them category 4 drugs. That means we give them 6 drugs for 4 to 6 months, and 4 drugs for next 18 months. In that case, take the opinion of an expert. Thank you very much.
Thank you, Dr. JB. Thank you very much. Sorry. So without wasting much time, we go on to our next speaker. And so there has been a slight change now because Dr. Nandita has to leave for another meeting. So I shall go on to Dr. Nandita straight away, and we shall take Dr. Gujral after we have taken her. So we all know her very well. She has been the most popular and dynamic past president of Foxy, and the most warm person, very friendly, with so many credentials to her credit. She is the professor of Ops and Gynae at D.Y. Patil Medical College, teacher of super specialty degree F&B reproductive medicine at Delhi, practicing infertility for the last so many years in various hospitals. She's the director of Bloom IVF Centers, Leelavati Hospital IVF Center, Bhatia Hospital Bloom Center, and D.Y. Patil Bloom IVF Center. And of course, she has spearheaded so many societies, as you can see over here. and she has, to her credit, many chapters and many awards. I won't talk about this much, but you can see over here that she's a very much decorated person, and we all love her. So today I have for you, Nandita, we are talking about ART, and we want you to tell us how to get a good pregnancy outcome in ART in patients of tuberculosis. So my questions to you are, what are the indicators for patient selection? Do you have any indicators which will tell you this patient will do good, at this patient you will have to tell her she's not going to do well? And when do you give what form of treatment? When do you decide whether it is an IUI? When do you decide whether it is going to be surrogacy, and so on? So what are the problems that you are anticipating such a patient when you are talking about tuberculosis? And when will you advise them third-party reproduction, which I just mentioned? And is there a role of immune modulation also in tuberculosis? Because we see this happening all the time in our clinical practice. People are giving all kinds of immune modulators to these patients. So with that, I hand over the slides at this stage now, the virtual medium to you. Please share your slides, and please, thank you so much for being here with us.
Thank you, Dr. Sonia Malik. I think it's been a pleasure, first of all. Thank you for that lovely introduction. And I think because you love me a lot, I get away with murder. So I'm really, I apologize. Dil se for this goof up which I've done today. I genuinely thought it was at 3 o'clock. But Kuldeep, thank you very much for inviting me. And JP Sharma, your talk was superb. I was really enjoying it. But unfortunately, I really have to get on with it. So, Sonia, tuberculosis is something which I see in my practice. I used to see it a lot initially, and it has reduced. Initially, when I was working at JJ Hospital, I still remember our OPDs, every second patient used to be on AKT. And you call it ATT in the north, we call it AKT in the west. And every single patient used to be on anticox therapy, I think. And that has definitely changed because it's not easy going on 6 months of therapy. So I think the criteria for selecting patients is very important. So if you look in IVF, when I want to do IVF on a patient, first of all, I think Dr. J.B. Agarwal has mentioned very beautifully, the history of the patient is very important. The family history, if she has any close relative who has had COX, or if she has had COX in the past. See, those which are obvious, I'm not going to talk about, like you do a sonography and you see a TO mass, etc. These are obvious cases. But I think the latent tuberculosis is something in our field which is a problem and which does lead to dilemma in our practice. And I think those are the patients. What I have seen is that one is a low ovarian reserve. Nowadays I see a lot of patients with low ovarian reserve. The AMH is low, the girl is young, but she has a low ovarian reserve. Now, this is a clinical sign where I start thinking of two things in my mind. One is either an autoimmunity, which may be there, or it could be tuberculosis. In our country, we have to think of tuberculosis also. So then the other things that are there is multiple IVF failures. If she has any history of PID, which has happened, or a very thin endometrium at embryo transfers. We've tried to prepare an endometrium, thin endometrium, on hysteroscopies, any kind of synechia, Asherman's, if we see, or a really flat endometrium, which is pale and not developing at all. So these are some of the signs in my practice, because what happens is I tend to do TB PCR. I know, hello. Am I still on? Sorry.
Yeah.
I tend to do TB PCR, but in selected cases, because what happens is with TB PCR with bacterial culture. Now, if your TB PCR comes positive and you don't treat the patient, see, I've had a medico-legal problem where we did TB PCR and we did IVF of the patient with bacterial culture, and we did not wait for the bacterial culture report to come. And even though the patient did not conceive, she said the bacterial culture was negative, believe me, but they still were upset with me and took me to court over that you did not wait for the for the report. So I think that's is there a problem happening in the Wi-Fi?
No, we can hear you.
You can hear me, okay. So that is something that we don't do. So I don't do TB PCR unless I have a good, strong suspicion. Then the other thing is that TB gold test. That's another test which I do. So these are the two tests along with bacterial culture which I do. Now, in my earlier on in practice, maybe 20 years ago, I have given empirical AKT to patients and they have conceived. Okay, we all have anecdotal patients like that. But now when I look back at it, after so many years of practice, so many years of wisdom, we don't know whether it was anti-tuberculosis treatment that actually made her conceive or, good IVF practices. So I feel today, as Dr. J.B. Sharma said, I think it's very, very important to actually document the patient. It's very, very important to actually have a positive history, have some kind of a documentation, a thin endometrium, a low ovarian reserve, where I can say that, okay, this patient could be, I'm suspecting tuberculosis. And there are very beautiful papers by Dr. Umesh Jindal and Dr. Malhotra and others who have said that treatment with tuberculosis in latent tuberculosis actually improves pregnancy rate. And I think those are the ones which I would go for. Sonia, if I would go for stimulation protocol, I think these people, they definitely require a higher dose of stimulation. The gonadotropin usage is much, much more. And if the tuberculosis is not treated, the quality of the eggs and the embryos is affected also. And also is the endometrium. Now, you talked about immunomodulation. Actually, in the endometrium, nowadays with the study of microbiomes and also with the study of interleukins, there's a lovely paper by Chakravarti et al. Which actually showed that the pro-inflammatory cytokines in a TB PCR positive patients are much lower. And it has been shown that tuberculosis causes a cytokine dysregulation in the endometrium, and that can lead to reduced implantation rates. We all know that the pregnancy rates are much, much lower, and definitely, the pregnancy rates are much, much lower in these patients. So I think the immunomodulation, rather than immunomodulation, I would rather treat the tuberculosis, but because it will take care of these cytokine dysregulation, the endocrine disruptors are also there. All these effects on the endometrium can be taken care if you kill this bacteria, and the gamma interferon and the interleukin-2 are the ones which increase in TB PCR positive patients. And I think with treatment, they definitely go down. So I would definitely work at that. And if the endometrium is really, really badly affected, I think here what really comes is I would offer gestational surrogacy as and when it's available right now, because I've done in a lot of patients. But of course, now the stem cell therapy, and I think we've got Sunita over here, she can talk about it, but stem cell therapy into the uterine cavity would probably help. And we do try everything, like giving high doses of estrogen, using GCSF, etc. But you know how the results are okay. But hysteroscopic adhesiolysis, I have found in these cases to have very, very poor results, even if we do it 5, 6, or 7 times. So I think the treatment of AKT and the latent tuberculosis, the treatment, if it is done early, you have fantastic results. The prognosis is very good. Yes, Sonia G.
So if I can sum up what you have told us.
Yeah.
If I can sum up what you have told us, number one, you should always suspect tuberculosis if you have a patient who has probably poor ovarian reserve. If there is another reason for it, it is unexplained. If a patient has got a bad endometrium, unexplained. And if she has, of course, osteomasis or any other kind of a symptom, which Dr. JB has alluded to. So if you have that, you probably are looking at tuberculosis. You should have them investigated. And if they are positive, put them on ATT and then take them up for IVF.
Yes.
During IVF, they require high doses of gonadotropins. They may have poor egg quality and number would also be less. And in such cases, you may have to offer them third-party reproduction. Is that right? Is that what you have told us? Okay. So is there any other question for Dr. Nandita before she leaves? Can I ask I cannot see anything in the chat as yet. I don't see anything in the chat as yet,
No,
Nandita.
Dr. Sonia, only thing I will like to highlight the role of hysteroscopic adenolysis.
You have to talk about it,
Yeah,
Dr.
I will be talking. Yeah,
So maybe he
yeah,
doesn't
but
agree with
because
me.
Nandita, yeah, because Nandita is leaving.
You also have to leave for a webinar, Dr.
Yeah. No, I don't. I don't have. I
That's
have already
Kuldeep.
finished.
So thank you so much,
Thank
Dr.
you, Nandita. Yeah, thank you,
I'm
Nandita,
very,
for
very
joining.
sorry.
Yeah.
I genuinely have mixed up
Thank you
everything.
so much.
But it was a pleasure being here with you.
Thank you so
Thank you.
much.
Excellent, excellent talk.
Actually, would have loved to be you having in the question answer session.
I know. I wanted to be there because there's so much to learn from you guys. Really.
So if you finish in time, please join
Yeah,
back.
I will join back. Definitely. Thank you.
Thank you so much for joining.
Bye.
Bye-bye.
So we move on now. I move back now. I will move back and I will take you on to Dr. Gujral. But just before doing that, I would just want to revise a little bit of what Dr. JB has said. I had actually wanted him to talk a little more about the case definitions as they have been proposed in the Index TB guideline. We know that there are case definitions over there. The presumptive extrapulmonary tuberculosis is a patient who needs to be investigated, presenting with infertility. This is a very, very pertinent and common question that people ask. Well, infertility itself is a symptom of tuberculosis. So should we investigate every patient? There is over here, it is written that this is a presumptive kind of a patient. So she can be definitely investigated. Confirmed patients are those who have gone through these tests. And then, of course, probable are these. So these are the definitions which are definitely mentioned in the Index TB guidelines, which I think all of you should read up in order to clarify your doubts. And of course, it also mentions who are the cured cases. So we have clear definitions of what are the different types of cases of tuberculosis. So please don't get muddled up. And then, like Dr. JB said, and I had actually given him clinical diagnosis, he still emphasized upon testing. And that is what brings me now to the next speaker as to how do we test and what do we do in the testing. So Dr. Gujral is, as you have already heard, she is the HOD and chairperson of Gangaram Hospital. She is in charge of high-risk pregnancy clinic, and she is the past president of NARCHI Delhi, past vice president of AOGD, past joint secretary of the Indian Menopause Society Delhi chapter, national vice president NARCHI. She is also editor of Journal of Fetal Medicine of India, and she is a member of the editorial working group of the current medicine and research practice. She has published many papers, and we all know that she's a great human being. We all love her, and she's a great friend to have in Delhi. So with that, I come to Dr. Gujral, and the questions, her topic is interpreting molecular and pathological tests to diagnose female genital tuberculosis. So how do we do it? And so my questions to you, Dr. Gujral, are, first of all, something which is absolutely bothering all of us. What is latent tuberculosis? How do you diagnose it? And then, which molecular tests do you use to diagnose all this? What is the role of gene expert? What is the role of PCR? Some of it has been alluded to by JB, but still. And then, how do you interpret and utilize these various tests in your clinical practice? This is going to be a very practical presentation which is going to tell us all these so that we can utilize it more and more in our practice. And with that, I stop sharing my screen, and over to you, Dr.
Thank you. Can I have my slides, please? Sana?
Yes, ma'am.
Please, just put me on, please. Well, let me begin by thanking Dr. Sonia and Dr. Kuldeep and all the organizers for making me read tuberculosis. I don't read it that much. So Sonia, I really need to thank you that you made me go through all the tests. And JB, I read all your books also. Gosh, what all you have written, So I may have taken a part from your book also, And
thank you, man. Thank you for honor.
I wish you had shown us the data you showed in your book. My God, it scared me. We in practice don't see that much of tuberculosis now. We see so much of endometriosis, and it made me think, my God, I should really look at the tuberculosis also now. Though we look after elite ones. Thank you, JB, and you made my job easier. So the contents of my talk would be, and Sonia, I will answer all your questions step by step as I go through these. We'll discuss the host response, what is latent tuberculosis, how do you diagnose it, and what are the difficulties in diagnosing a genital tuberculosis in general, the methods, pathological, immunological, molecular, biochemical, and overall, how to interpret and utilize these methods in clinical practice to decide on the treatment. Next, Sonia. Sonia, please, next. Right, when you, this is very, very basic pathology that when mycobacterium attacks the body, whether it is the endometrium, the tube, the lung, or anything, it is going to trigger a complex immune response. What is it? It's a pool of long-lasting memory T cells which are directed against MTB antigen. Macrophage, we know, comes as the first line of defense because they can ingest and subsequently kill the pathogen. Tissue reaction is going to occur at the site of infection, leading to the formation of tubercular granuloma, which contains, as JB said, macrophages, T cells, B cells, lymphocytes, fibroblasts. And this is what will come as a histopathological diagnosis, your specimen stored in formalin. Now, T lymphocytes also can kill infected cells, but they've got the capacity to secrete cytokines, interferon gamma, commonly called as IF and gamma, and this activates the macrophages. So when this interferon gamma is secreted, your immunological test like a TST and IGRA will come to them, will get positive. And it takes at least 3 weeks for this phase of to reach for the IGRAs to be positive. So if you're lucky to catch a patient in a very, very early stage of disease, which is highly unlikely, you will not get an IGRA positive. You may just culture the bacteria or see an AFP. Now, Mycobacterium bacilli can persist in macrophages, having developed immune escape mechanisms. The mycobacterium, which don't die off by the body defense, they are still persisting. But they may be few, so you may not get them at the culture at this time. Here comes the role of molecular diagnosis, the molecular diagnosis techniques to amplify, and even a small amount of bacilli, you can pick it up. Earlier on, when you had the, attacking bacteria, you may even just get the culture. Now, this whole immune response takes 4 to 6 weeks after the primary infection. And what is it? Balance between the immunity of the host and the multiplication of the bacilli, which determines the outcome of infection. You can get a primary active infection, you can develop an adequate immunity, or you can develop latency. And reactivation and development of post-primary TB can occur many years after latency. And I'm glad, JB, backside please, you highlighted that if a girl at puberty, when we were students, we used to read TLT news, and that line was written there that if a girl gets pulmonary tuberculosis at puberty, be sure her genital organs are going to be, affected at that time. So that's what you brought it out. So this is what is your immune response, whether you take the disease, you kill the disease, or you remain latent and become active many years later. Next slide. Now coming to the latent tubercular infection, what is it? We go by the definition of CDC, which says it's a condition in which the individual is infected with mycobacterium, but currently does not have active disease. Persons with latent tuberculosis are asymptomatic. They have a negative chest radiograph. They are not infected to anybody else. So what do? We should believe that this mycobacterium remains viable with latent infection, but it is quiet, it is dormant, it is not causing the disease, but it has the capacity or the potential to cause the active disease. This is where all the IVF people want to treat a latent tuberculosis with the fear that the acquired bacteria, bacilli, may just grow up and cause an active disease when either they're doing ART procedures, they can precipitate it, or altered immune status. Therefore, if you put it simply, it is two sides of the edge. On one side, the bacilli is lying dormant, but it is live. It can get to a subclinical infection. It can go on to a full active disease. Therefore, latent tuberculosis should not be discarded. But the problem is the diagnosis. And there are only two diagnoses of latent tuberculosis. We shall detail them little later: tuberculin sensitivity test and the IGRA interferon gamma release assay. Next slide, please. Next slide, please. Yes. See, it's difficult to diagnose tuberculosis because it's always genital tuberculosis, always secondary to lesion in the other part of the body. That's why JB highlighted that you must look at every part to see whether you have a node, whether you have a sinus, whether you have a lung healed lesion, and then if you have suggesting the genital involvement, at least you can, pick it up. The diagnosis is delayed because patient's significant organ damage has occurred by the time patient reports. And the nature of the bacilli, I can hear some noise if somebody can unmute. Paucibacilli, the nature is paucibacilli, which is again a challenge to diagnosis. Many NMTB organisms attack like that, difficult to diagnose by the test. And one of the biggest problem, as I said, is diagnosing latent tuberculosis, and we believe it should be. Next slide, please. Next slide, please. So this is already said, but just to recapitulate, histopathology is a definite diagnosis. When you do an AFP staining, you require 10 raised to power 4, 10 raised to power 6 bacilli per ml of the tissue or fluid to give a positive result. Therefore, detection rate is only 10% by the Z-Nelson chain. The fluorescent would have slightly improved. Culture needs lesser bacilli, 10 to 100 bacilli per ml of the tissue. This is the gold standard of diagnosis. Solid cultures take 8 to 12 weeks. Liquid cultures maximum 1 to 7 weeks. And Bactec MGIT 960, they are the recent liquid cultures, accurate and 1 to 2 weeks. As JB has highlighted, that how to take the specimen divided into 3 parts, should be free of the blood. It should be in saline for the test and for formalin for the histopathological diagnosis. Next, please. Yeah. So for immunological test, tuberculin sensitive test is the one. This supports the diagnosis of latent tuberculosis. It's in vivo, we know dermal injection of Mycobacterium and identification of immune response that is in duration after 48 hours. Now, what are the limitations? The antigen we use is not specific to MT. And a positive test cannot differentiate whether you have an immune response because of a previous BCG, and most of us have had it, or exposure to non-Mycobacterium tuberculosis or a Mycobacterium tuberculosis infection, and you cannot repeat the test. So positive test does not lead you anywhere. All of us maybe during the seminar would be having a positive test. So negative test should be looked into. Negative test means either the patient has not been exposed to tuberculosis at all, or is immunocompromised, or or she has a miliary tuberculosis. Next, please. Next slide, please. Now, coming to interferon gamma release assay called as IGRA, this is a vitro detection. It's a blood detection. It detects cellular response to MTB specimen antigen in the whole blood. You put the antigen in the blood and see this response. It measures the release of IF and gamma. Antigens used in IGRAs are absent in non-Mycobacterium tuberculosis. BCG does not affect it, and MTB does not affect it, unlike TST. And it can be used for a serial testing. TST cannot be used. But it should not replace standard diagnostic methods of TB. This is what the CD states. It contributes information as a part of general diagnostic workup. We'll detail that a little later. If you have a negative IGRA, this does not mean that you don't have tuberculosis. And if you strongly suspect, repeat in 4 to 6 weeks. As I said, the reaction takes minimum 3 weeks. Intermediate test, technical factors, inoperable blood storage, impaired immune response are the causes, so discard them. Commercial kits are quantiferon, quantiferon gold, TB spot, and TB sure. Next slide, please. Right. Quantiferon TB was the initial test. The antigen used had a Mycobacterium avium too, so not very specific, given up. TB gold, quantiferon TB gold, this is a more definite form. It uses antigens CFP10 and ISAT6. These are specific to Mycobacterium tuberculosis. You get the results in 24 hours. BCG does not affect it. Quantiferon TB Gold Plus, TB Sure is a newer one. Same way, in blood, it detects CD4, CD8 T-cell response. This can detect latent TB. CD8 indicates multiplying Mycobacterium within macrophages. Hence, the person has active TB. And CD4 says it's a latent tuberculosis. You can do tests at 0, 3, 6 months to see response to the anti-tubercular therapy. One important thing is when you do these IGRA tests, you process the blood within 12 hours because WBCs will die then. Send it after 24 hours to the lab, it has no meaning. Next, please. Now, IGRA commercial test, the new one, we've not used it. LC spot or TB spot, this is latest, new. It diagnoses both active and latent tuberculosis. It again takes peripheral blood gamma interferon secreting T cells in response to TB antigen. But these cells are counted as spots on the test plate. It's an ex vivo T cell based assay for detection of immunity using detecting microbacterium. The more number of spots, the more active infection. Next, please. Now, molecular tests are the PCR and NATs. A lot has been said about PCR. It's a rapid test, takes 1 to 2 days. It's a sensitive, specific method of detecting Mycobacterium tuberculosis. MTPT 64 is used to amplify it, but it can pick up a single mycobacterium. It cannot differentiate between live or dead bacteria. False negatives could be due to contamination. So, as my speakers have said, ATT should not be started sole on the basis of a positive PCR. Next, please. Next slide. Now, molecular tests, the NATs, nucleic acid amplification test, the principles are that it detects and distinguishes Mycobacterium tuberculosis organism. It amplifies DNA, RNA to rapidly identify microorganism in specimen, that is a tissue. Result is available in 48 to 72 hours. It identifies non-tubercular mycobacteria, can detect rifampicin or the drug resistance. Sensitivity is around 80%. Specificity is high, 98 to 99%. Sensitivity is lower in AFP negative. Now, limitations are inhibitors in specimen may prevent application, hence you get a false negative. Tests again do not specify organism live or dead, can remain positive in patients who are on anti-tubercular therapy. You cannot use this for follow-up, and it cannot be used for the diagnosis of latent tuberculosis. Next, please. Next slide, please. Now, the tests are DNA ampiclor and gene expert. I'll just come to it. RNA EMTD is a single tube nested reverse transcription PCR, has been tried. Result is available in 2 hours, but RNA of the mycobacterium dies within 3 minutes. So how will we get a very specific result on this? As of no. As of today, we have a gene expert. This is what we use. Sonia, you asked me that. And this is, as Dr. JB showed, it's a beautiful cartridge. We test using a cartridge, built-in cartridge, FDA approved, specificity 99%. Entire process is carried out in a closed system. So therefore, no contamination. You just have to put the tissue in the area you're supposed to put and get the result in 2 hours. It can also test for rifampicin resistance. Next slide, please. Next slide, please. Now, adenosine diamine activity, ADA. We as gynecologists are not using that much of this test like our physician friends are using, doing the ascitic fluid and taking level of more than 30 mcg per liter as significant, and they can start treatment if you have that much level. So I think what we should incorporate that when we are putting in a laparoscope, wee bit of fluid in the pouch of Douglas, we can at least start doing ADA. Now, tuberculostic acid test was a fatty acid based test on a gas chromatography. This was just taken from the material, but I have no experience on it. Then if you have a small number of bacteria, you can get this biochemical test positive. Physicians are again using both these tests in the ascitic fluid. Next, please. Next slide, please. Now, having learned all the tests, the molecular ones, the IGRAs, the immunological ones, and the biochemical ones, how do we decide on the treatment? It's making it very, very simple. If you have an active genital tuberculosis, that is, you have a culture positive, you have histopathology positive, you have imaging positive, laparoscopy, histoscopy, anything positive, no two opinions, full course of anti-tubercular therapy has to be given. When you put in a laparoscope to evaluate, you may have a healed tuberculosis, where you have adhesions on diagnostic lab, you have intrauterine adhesions on histoscopy, but your culture, NAT, and AFP are all negative. This is tuberculosis. It actually does not need treatment and it doesn't need a repeat test also. But one school of thought is that if we believe that bacilli can be viable in these healed lesions, and if we go ahead and do an ART procedure, can we, can the disease become active and the woman can get a full-blown tuberculosis? That's a matter of debate. But if you want to do it, then in these cases, you consider IGRA. If IGRA is positive and all the lesions are healed, you want to do an ART procedure, makes some sense if IGRA is positive to give her 6 months of anti-tubercular therapy. Next, please. Next, please. Now comes a subclinical female genital tuberculosis, unexplained infertility. Now you have various combinations. You have a normal endoscopy, you have a positive IGRA, you have a NAT positive, you have negative PCR and negative AFP and negative culture. Now this is a case where you should give her an anti-tubercular therapy because this could be an early possibility stage of infection and it can reactivate. This could be just a little latent tuberculosis also. No repeat testing, give ATT and go ahead with your ART procedure. On the other hand, you have a case where you have an endoscopy as normal, IGRA as negative, but only NAT is positive, Cox culture is negative. Now this is a very difficult decision to make. Ideally, you should not advise treatment based only on NAT positive in the absence of any other signs or symptoms. It can be a false positive. So you could repeat once is you could repeat IGRA in 3 months' time. If she converts from negative to positive, you could think of an ATT. And if you are very, very suspicious, no, this is going to be tuberculosis, this cannot be a false positive, then you do a gene expert test, reconfirm. If you still get positive, to make your own choice. Now, if you have a normal endoscopy and only positive IGRA, negative EB, negative NAT, culture negative, this is a case, as had been highlighted, no treatment is required. This indicates exposure to Mycobacterium tuberculosis, does not indicate infection. In endemic countries, latent tuberculosis should not be treated based only on a IGRA test. This is the best I could make out of the tests. Next slide, please. So to sum it up, diagnostic tests for female genital tuberculosis should be used and interpreted along with clinical scenario. Thank you very much.
Excellent talk.
Dr. Gujral, that was an excellent overview of all the tests and very clear.
Please.
Very well put, very well explained.
Your book was a lot of input, you know.
When we should do what? That was most important, when we should do what. So basically then, now as she says, very clearly we have to select our test. And there is this new test that she has talked about, and that is basically, she's talked about this, and with that I come to my next speaker, but I would like to, although you have already been hearing him all through this, and people have been referring to Dr. Kuldeep Jain, but let me introduce him to you formally before he takes on the mic. And we all know him as the director of KJ IVF and Laparoscopy Center at Delhi. He is the program director at the KJ IVF Center, also at Faridabad. He was the founder secretary and the past president, and I would say he's still the pulse of IFS. And he's the chairperson of the International Exchange Committee of IFS, has been running it very successfully for the last 4 years. Editor-in-Chief, Fertility Science and Research, member, Board of Directors of IFFS 2016-19, the organizing secretary also of the same Congress, chairperson Infertility Committee, AOGD, member Education Committee, International Federation of Fertility Societies, and he has served FOXY in various different roles for the last 35 years, was Endometriosis Committee chairperson from 2016 to 2019, North Zone Coordinator, Infertility Committee member, FOXY member, International Exchange member. You can see that the list is long and really long. So it just says that Dr. Kuldeep Jain has been working in these organizations with all his heart and zeal. And I am here to tell you all that he is now contesting for the post of Vice President. So it is our request and it is our appeal to all of you to please vote for him, because you know that he's an academic person and he really knows what should be correct and what should be done properly. So I expect all of you to please come out and vote and support Dr. Kuldeep Jain for his candidature for Vice President FOXY North Zone in the coming election. And now I hand over the mic to Dr. Kuldeep to introduce our next illustrious speaker. Dr. Kuldeep Jain, please share your screen.
Thank you, Dr. Sonia, for kind introduction, and of course I need support from each and every one of you in my next task which is in my hand, that is playing a bigger role in Foxy as Vice President North Zone. So thank you very much. Now I am introducing a person who is actually means the world will fall short.
Yes.
Yeah, he is a true leader.
So introduction.
He is a true leader, and he has been headed actually almost all major organization of India as it comes to option gynae, endoscopy, ultrasonography, infertility. So all major organizations he is head. He is Dr. Narendra Malhotra. He will be speaking on how we treat in pregnancy once the patient has conceived. It is very difficult. Basically, the conception is very difficult, and once the patient conceives, the problem are not over. So many a times the patient will come to you in early pregnancy loss or in the mid trimester loss. So I think he is going to tell you all problems which these patients they face when they conceive, and how he treats and what are the recommendations, what are the evidences. Can I see my slide, because I had to yeah, just a minute, Naren. I will ask a question from you before you start. So Naren, my questions from you, once the patient is conceived, is TB in pregnancy different, or is there any problem when the patient is having TB and having pregnancy? What are the reported complications in pregnancy in genital tuberculosis? Is it only with pulmonary tuberculosis, or do we have cases of genital tuberculosis as well in pregnancy? Another question which is very important coming from a lot of attendees, that is, can she breastfeed when the patient is having genital tuberculosis or pulmonary tuberculosis? What about congenital tuberculosis? Is it passed on to the fetus? What is the drug regime for pregnancy and lactation? When the patient is already on anti-tubercular, should she stop? Or is there any other regime which she has to start? And can she continue anti-tubercular treatment during pregnancy? And of course, now the tuberculosis is notifiable, but whether you have to notify genital tuberculosis also as a separate entity. So, Dr. Naren, floor is yours.
So thank you very much for the kind words of introduction. Fantastic introduction to this topic, especially the testing part, which I've also learned a lot today. What are we going to do is try to answer all these questions. The first reported pregnancy with tuberculosis was Charlotte, who was a novelist, 1816 to 1855, and who died because of this disease. So that is the first reported. So my first question, which I've been given by you all, is that is tuberculosis in pregnancy different? Well, tuberculosis in pregnancy is different, because tuberculosis in pregnancy are two types of different stress which the women experience, and their simultaneous presence affects both of them physically and mentally. And to the concerned physician, genital tuberculosis presents a diagnostic challenge. We've all heard that. And the management of the underlying disease in a pregnant woman requires some extra care. So the management of such cases in context to the revised National Tuberculosis Program, or what you call as RNTP, which you'll be seeing in my slides, and the adoption of the DOTS program, or Directly Observed Treatment Short Course, is the new strategy. We've all heard about the incidents. Let me take you to the incidents reported in 2015 on pregnancy. From Belgaum, 8 out of 362. Similar figures from UP, Jharkhand, and which may be more. We in the last 5 years have dealt with 25 cases of pregnancy with tuberculosis in our 7,000 ANC cases and about 4,200 deliveries. In India, tuberculosis is a notifiable disease, whether it's pulmonary or genital, you have to notify. Also in pregnancy, it is different because it causes death, so it kills. So pregnancy tuberculosis is different because it kills, and the disease is responsible for killing more women of the reproductive age group than all the other combined causes of maternal mortality. So we need to remember this. 2 deaths occur every 3 minutes due to tuberculosis. That means almost 1,000 a day. It's worse than maternal mortality. And in pregnancy, the risk is different. So anybody can catch tuberculosis, but it is possible that pregnant women have a higher risk of catching tuberculosis. Some people who are at more risk, who live in the same household with someone who's involved, lungs are involved, have lived or worked in a country which has high tuberculosis, are unable to fight infections, immunocompromised, other diseases, and are underweight and are dependent on recreational drugs, which are like alcohol and drugs. So in pregnancy, the symptoms of a pregnant woman can be totally non-specific also. So those that suggest that she has an active tubercular disease require further assessment by the methods which have been described. Cough persisting for more than few weeks, persistent fever, high fever here, not the evening rise, heavy sweating at night, loss of appetite, unexplained weight loss, generalized unusual sense of tiredness and feeling, coughing up blood, and persisting swelling in the neck glands. So we suspect these women, and we suspect them, and then we reach the diagnostic dilemma of how to test them. So a pregnant woman with extrapulmonary tuberculosis has constitutional and organ infection symptoms also. So that complicates the whole thing. So we do the diagnosis by sputum, by the newer gene expert or the NAT, which is, I believe it is the government of India in the latest guidelines has said it is notifiable and only NAT test will be allowed. Nothing is allowed. You cannot do Montos, you cannot do, that's what I've heard. I need to clarify this. And we should follow the RNTCP guidelines of sputum and for the gene expert. So this guideline is highlighted, this table is highlighted very nicely. And if you get that, then you decide on whether you have to treat or not. So my second question, which you all gave me was, or which you just asked me was, what are the reported complications in pregnancy? Now the reported complication to the mother and baby both. The babies will be low birth weight, premature, congenital tuberculosis, increased neonatal and maternal mortality, increased pregnancy complications, abortions, PPH, and preeclampsia are some of them. We have to be careful. The consequence of tuberculosis on pregnancy is pregnant women with pulmonary tuberculosis who access an early appropriate treatment will have lesser complications. If the treatment is started early, the complications will be less. Therefore, it is very, very important to prevent tuberculosis in pregnancy and to diagnose it early and treat it early. The mother and the newborn, the fetus can get affected by tuberculosis by hematogenous spread through umbilical vein to the fetal liver or by ingestion or aspiration of the infected amniotic fluid. So true congenital tuberculosis is believed to be rare, but the risk to the neonate getting the tuberculosis after birth is more. So newborn can have congenital tuberculosis, and if you suspect it when it's born with respiratory distress, fever, poor feeding, lethargy, irritability, abdominal distension, lymphadenopathy in the newborn, and hepatosplenomegaly. The third question which you just asked me is the complication only with pulmonary tuberculosis, or do we have cases of genital tuberculosis as well in pregnancy? Well, extrapulmonary tuberculosis can always be there, and you have to think of them and you have to look for them. A simple per speculum could show you a tuberculosis of the cervix, and then of course the histopathology and FNAC of the site where it is, depending on the ultrasound findings on where it is, the extrapulmonary tuberculosis should be diagnosed. Now the other very important question was, can the mother breastfeed? Breastfeeding is encouraged, as tuberculosis drugs do not harm the neonate. They go into the breast milk a little bit, but they do not harm it. A mother can infect the newborn only if she is infectious, if she is coughing. Usually this is the only case if she has a cough and is not on treatment. So a woman under anti-tubercular treatment can breastfeed her infant, taking the precaution of cough hygiene, and she should cover her mouth and nose with a cloth or a mask while she's breastfeeding. As it is these days with corona, we have to mask ourselves. What about congenital tuberculosis? I just mentioned it. It's very rare for the baby to be born with active tuberculosis if the mother had TB. But a neonate having tuberculosis may present with all these symptoms. And if these symptoms are there, then you think that the baby has brought tuberculosis from inside. Now, my last questions, and this is where all the difficult part arises. What is the treatment regimen for tuberculosis in pregnancy and lactation? This is what we need to be very, very clear. So there are guidelines of treatment of tuberculosis in pregnant women and newborn. First of all, you have to categorize the case into category 1 or category 2 according to the RNTCP guidelines, and depending on whether she had a previous history of anti-tubercular treatment. So category 1 is new case or a case which took less than 1 month of treatment. And category 2 is a retreatment case or the one who was 1 month previously categorized as new cases. The critical key points for treatment is you consider the potential risk of tuberculosis to the fetus and the mother. So the benefits of treating tuberculosis in pregnancy outweigh any risk of the treatment. Although some amount of anti-tubercular drugs come out in the breast milk, but breastfeeding is not contraindicated. I am telling that again and again. So our first line of treatment would be the standard first line regime, which we follow in non-pregnant women: isoniazid, rifampicin, pyrazimide, ethambutol, or what we call it Refa-4. And they are not contraindicated in pregnancy, but they require a monthly liver function test. And any time the liver function test gets altered, stop the treatment and go for it. Now we have 2 international guidelines and then we have our own Indian guidelines. So the international guidelines of the International Union Against Tuberculosis of Lung Diseases say you follow the standard first line drug treatment in pregnant women as you did with the non-pregnant. The CDC, however, said that we cannot guarantee the teratogenicity of pyrazinamide because of the lack of studies or a lack of data. But the experience of using pyrazinamide says it's pretty safe. So the CDC gave us a regime which is 9EHR, and I will just tell you what this 9 and HR and E and all these letters stand for. So treatment has to be started promptly, same regime, intermittent regime as the DOT strategy of RNTCP. That means instead of giving every day, you give it thrice weekly. 3 days a week, the treatment is given. And that should be as good. So WHO is Refa-4. So we are not discussing drugs except streptomycin. I have not said streptomycin. So isoniazid, safe in pregnancy, safe in breastfeeding. Rifampicin, safe in pregnancy, safe in breastfeeding. Ethambutol, safe in pregnancy, safe in breastfeeding. Pyrazinamide, no safety in pregnancy established as of yet, but with extensive experience, it is considered as safe. Or you go to the 9EHR and remove the pyrazinamide from the 4 drug or Refa-4 regime, as an alternative regime has been suggested by CDC, the 9EHR, and I'll just tell you what it is. So category 1 needs DOT regimen. DOT is the direct observed treatment short course. That means the treatment is being observed by someone. And then we give 2H3, R3, Z3, E3. So these numbers are the capital 2 and 4, which comes after the slash is the months. So 2 months of H3, that means isoniazid, rifampicin, pyrazinamide, and ethambutol. So 2 months of all these 4, and then 4 months of H3, R3. And this small 3, which is the prefix, denotes the number of doses in a week. So we are not giving it every day. So it is not 2H7. It is 2H3, R3, Z3, and E3. So 2 months like that, and then 4 H3, R3. So 4 months of H3, R3. So 6 months of treatment is what we are giving. And the doses are, we all know, 450 of rifampicin, 600 of INH, 1,500 of pyrazinamide, and 1,1200 of ethambutol. If the woman is more than 60 kilos, the rifampicin is increased to 600. And the doses are given according to the DOTS date. The DOTS date is that they call the patient on the same patient Monday, Wednesday, Friday, and a different set of patient on Tuesday, Thursday, Saturday, and Sundays is off. So whichever days, so DOT or the direct observed treatment is followed up. Now we know the side effects, so I'm not going to go into detail. Minor side effects will be there, but the major are the jaundice, and if there is a jaundice, stop the treatment and refer her for complete evaluation and change it. So these treatments are domiciliary based. So the patient comes to the DOT center only for the first dose of the week. So, and then takes the 2 other doses of the week and comes back again on Monday to take the Monday, Wednesday, Friday dose back. Now you can have domiciliary, but if the patients are serious, then they go for the intensive phase, all 3 doses in the week given by the DOT provider. And then they continue, once they go out of the intensive phase, they continue with the domiciliary treatment. 1 dose they come to the DOT center and take, and the rest they take it. So for category 2 patients who are reinfected and the treatment have been taken earlier, but for at least 1 month, and they're still getting it. So here it is 2 months of, if she's not pregnant, before pregnancy, streptomycin has added 3 days. And then 1 month of 4 drugs, and then 5 months of 3 drugs. So 2 months of 5 drugs, H3, R3, Z3, 3 days a week, 1 month of 4 drugs, and 5 months of 3 drugs. Except injection streptomycin as soon as she gets pregnant, or if she's pregnant, stop the streptomycin, restart it if the treatment is not complete after the delivery, or give it pre-conception. Please note that intensive phase of treatment in both Cat 1 and Category 1 and Category 2 will be extended by 1 more month if the follow-up sputum or the follow-up test is still showing positive for AFB. So 1 more month. So instead of 4, we'll do 5. Instead of 2, we'll do 3. So capital that 2 will come. And those patients who are very sick or who have tubercular pericarditis, meningitis, extrapulmonary tuberculosis, and seriously ill, steroids are added to it. Also note that the regular follow-up is going to be done by the treating doctor, in the pulmonary by sputum, extrapulmonary by regular clinical examination and ultrasound. And if we get the spot TB test, we will use that. Otherwise, we go for the NAT or the gene expert, or even the PCR test. A woman undertaking anti-tubercular treatment can breastfeed with proper cough hygiene. Again, if there is HIV along with it, follow the NACO guidelines of 2013 for HIV with tuberculosis treatment. If there is a multi-drug resistant treatment, multi-drug means that she is resistant to isoniazid and rifampicin. And you remember the gene expert test which Dr. J.B. Sharma showed, that does the rifampicin sensitivity also along with it on positive. The extensively drug resistance or the XDR tuberculosis is that they are resistant to other drugs also, the fluoroquins, the amikacins, and the kanamycins. So multi-drug tuberculosis has to be again categorized into category A, B, and C, criteria A, B, and C. And then you follow the new treatment guidelines. And the question to all of you is, to the audience, can you answer? Need to consider risk benefit for the mother. So option 1, if the patient gets pregnant, should we stop or delay MDR treatment? Option 2, should we terminate the pregnancy? This is my MDR. I'm not talking about normal tuberculosis. Option 3, continue the treatment while she's pregnant. So these are the 3 options which you need to find. Let's discuss it. So the recommendation is that the patient, you give individualized care, the patient, involve the patient in the decision, and pregnancy only because she is drug resistant should not be terminated. But the option is given to her. All women of childbearing age who are receiving MDR tuberculosis therapy should be advised to use birth control, not to get pregnant. But if they get pregnant, then you can continue the treatment. And then you continue with 6 months of 9, you see 9, kanamycin, levofloxacin, ethonomide, cycloserine, pyrazinamide, and ethambutol. And then 18 months, 9 months of this, 6 to 9 months, 18 months of the 4, and you can reserve or substitute PAS, MFX, moxicloxacin, and carbamazepine. So these are for the multi-drug or the XDR resistance. So managing multi-drug resistance, first establish the gestational age. If she is in the first trimester, then it is advisable that you can advise her MTP. If she's crossed the 20 weeks, then MTP is not allowed in India unless it's life-threatening and with the court permission, that can be offered. But if less than 12 weeks and she wants to continue, then kanamycin and ethanamide are to be omitted and PAS has to be added. So then the duration, as I told you, 6 and 9 months, and then followed up for rest of the treatment for 18 months. So again, here also you have the intensive phase and the continuation phase. So intensive phase for 6 months and the continuation phase for 18 months. And this is the RNTCP policy against any empirical treatment of it without any. So for drug resistance, it is notifiable. It has to be certified by an RNTCP certified laboratory, and then only you can do. No empirical treatment of kanamycin, PAS, moxicloxacin can be given. It is medico-legally not allowed, and you are liable to be, your license is liable to be confiscated if you start XDR treatment without getting it tested in a government lab. So the recommendations are very clear. So XDR and MDR treatment can be continued, but we need more data, and the choice, of course, remains with the patient. There are some adverse effects of ATT in the fetus. First line of drugs are safe. It is only the streptomycin and the kanamycin which will cause congenital deafness, and that has to be avoided. The side effects of second line drugs, ethanamide, GI upsets, kanamycin, nephrotoxicity, cycloserine may include suicidal tendency, so we have to remember all these if the patient is there. And the warning goes is poor treatment practices will breed drug resistance. A good treatment prerequisite has to be established so the MDR does not come only, and a very good quality DOTS program should be followed, and we should prevent the MDR emergence when we are treating. So to summarize, ladies and gentlemen, the diagnosis and treatment of tuberculosis in pregnancy is a real challenge. Pregnancy is not a contraindication for treatment of tuberculosis. Good quality treatment is the prerequisite. Treatment must be adhered and ensured. So you have to follow that up. Special precautions for extrapulmonary tuberculosis, MDR and XDR have to be taken. You have to keep the comorbidities in mind, especially HIV, then go to the regime as by NACO, and over and above, tender loving care, proper counseling, supervision, reassurance plays a key role for the success of treatment. So in spite of the side effects mentioned, tuberculosis drugs are reasonably well tolerated in pregnancy, and follow the guidelines and follow it that it is a notifiable link. Let's together fight tuberculosis and save the mothers from dying from at least this preventable cause of tuberculosis. 24th March is the World Tuberculosis Day, and we should all be talking about awareness on those days. Thank you very much for inviting me here to this wonderful session on tuberculosis. Thank you very much.
Thank you, Dr. Narendra. That was an excellent talk. Yeah. Before Dr. Kuldeep starts with the next one, I have one question before you leave. Can you just tell people the steps of notifying tuberculosis? You are so good at the various steps of our NTPC program. So kindly tell us how to notify. What is the website?
So we have a website, we have a form, and we have a register which we have to maintain. And we are in Agra, they are asking for a physical register copy. As soon as it comes test positive, then we have to send the copy on once a month. And we have a WhatsApp group on the doctors by the tuberculosis center. So immediately when we get a positive test, we have to put it on that group. So that fellow advises us that if she wants a free treatment, she can come to the DOT center, or you give her this treatment if you want to prescribe the treatment. So you go to the website, fill that form, keep the register, and notify to the district tuberculosis officer on your mobile on the WhatsApp group, which they have usually.
Thank you very much. Thank
you.
you.
Dr. Sonia, if you allow me.
We will discuss later on. Can we do that later on because he has to leave? Why only?
Yes, for his lecture.
I'll come back in 20 minutes. I'll be back.
If you allow me 1 minute only.
Yes.
Dr. Narendra, thank you for your excellent lecture, but there have been some changes which we must tell the House. You know, National Tuberculosis Control Program is changed now. Its name is National Tuberculosis Elimination Program. There has been major change. National Tuberculosis Elimination Program. Number 2, there have been major changes. Their categories have been stopped. There are no category 1, 2, 4 anymore. And that there is a major change in treatment. We don't give RHD. Hello? Okay. Hello?
Hello. Speak on.
So now we have to give 4 drugs daily. That thrice a day, weekly.
So the three a week is gone.
We have to go give 4 drugs daily for 2 months, and then we have to give 3 drugs daily for next 4 months. So 2 drugs is gone.
For next 4 months.
Yeah. So 4 drugs daily for 2 months, 3 drugs daily for next 4 months. That is the latest.
For 4 months.
We don't use the category 1 is gone now, and there is no category 2. Streptomycin is gone. So those patients, even who are defaulters, even they are started category, which we used to call category 1 only. We don't use the term. So they are also doing RHD and RE, but you have to rule out MDR.
Yes.
Because the logic is that if they are drug sensitive, they will still respond to RHD. And if they are drug resistant, they will not respond even to streptomycin. So then you have to give them, which you used to call category 4 before. And then there has been some change in the treatment also of MDR tuberculosis. So we now give 6 drugs, which are bedaquiline, levofloxacin, linezolid, cycloserine, ethionamide, and clofazimine. So these 6 drugs are given for 6 months, and then we give we stop bedaquiline after 6 months. So we continue the 5 drugs for next 12 months. So total 18 months. So these are the major changes by WHO and Government of India.
Dr. JB, we are going to take the treatment with you once again after this because that is not very
clear. No, because sir has to go now.
Yeah.
Another excellent talk.
Change.
Yeah.
I think we should discuss again. Yeah.
I think Dr. Narendra, it was.
Back in 20 minutes or so.
Yeah. So we will be waiting for
I'll join back.
Yeah, thank you very much. It was really excellent talk and really to the point, very clear messages how it should be treated in pregnancy when it comes to tuberculosis. So thank you very much. I will be waiting.
We'll modify the categories, Dr. J.
Yes.
Yeah, we'll modify and circulate the categories.
Yeah. So thank you. Please join us again during question answer session. Now I will be inviting another leader who is actually, I really admire her energy. She is president of Indian Association of Gynecological Endoscopists, and apart from that, she is having so many credentials to her credit. Can I have her CV? Dr. Sunita Tandulwalkar. I am very happy to have you in this discussion. She will be speaking on, which is very favorite for her, endoscopy in tuberculosis as stethoscope. So that is her topic, and I will like to have few questions for her. So, Dr. Sunita, what makes you suspect tuberculosis, and when you plan a laparoscopy or a cystoscopy for her? Another question is, what are the confirmatory signs of female genital tuberculosis on laparoscopy and on histoscopy? And what are the indications of surgery in female genital tuberculosis, since first line is ATT? So whether you do diagnose by endoscopy and then you start ATT, or you have to go for some laboratory test before you put a scope, or you have to exclude tuberculosis before you go for surgery in these cases. So these are some of the questions which I will like you to highlight in your presentation. So I present all of you, Dr. Sunita Tanulkar, stage is yours. Dr. Sunita, please.
Hi, Kuldeep. Thank you so much for this opportunity. It is always wonderful to work with you and Sonia. Hi, Nirja. JB, sir. Thank you, madam. And let's start it. Can I have slide share? So when should we take this patient for surgery is the most important question you asked. The surgery is usually done when you wish to have either diagnosis, so it is for the diagnostic purposes. Secondly, if patient is having a pain and conservative or anti-tuberculous treatment which we have started is not resolving her pain, or there is a mass or something, or you want to improve your fertility results. So let me start addressing how we should go about it. We are what we repeatedly do. Excellence is not then an act but a habit, Aristotle said, and I think we all follow that. Endoscope is my stethoscope. Thanks to Sonia, I never had this topic and endoscopy on this. Last 48 hours, I really sat and took out my all videos, and I'm really happy for it. So what I want to say, friends, is endoscopy has given us an opportunity to help our patient in best possible way. Dr. J.B. Sharma has highlighted, I think from his book only, I must have taken 16% of the cases, and around 50% of the genital cocks will present to you. And as he said, high index of suspicion is needed, especially in our country. How we say every pregnant lady coming with 6 weeks and pain, high index of suspicion for ectopic, same way for the cocks, even for the subfertility. I think I have deleted few slides because Dr. J.P. Sharma has shown us beautifully the subacute stage, what these tubercles are, and I included the videos. Hydrosulfings, multiple these small tuberculosis, flimsy adhesions, all this is typically you will see in a cox patient when you put it. While in chronic stage, as he said, the hydrosulfings, pyosulfings, caseous nodules, amount of videos. Now, typically these patients will have a malaise, dull aching pain all over abdomen, not losing weight, no appetite, evening rise of fever. Typically, you should, when you put the scope in, you see that. Infertile patients, this is the scenario. You can't even see the uterus and adnexa. You see a lot of inflammatory tissue, the reactionary fluid. What is important and why I'm showing you this video little more is because many time it is a cox. If you see the entire momentum is stuck and you need to pray. I pray and then put the scope because you can go through and through to the bowel because bowel is like this stuck and you even may not know because you have gone through anterior and posterior wall both through the lumen and you are entering in. So make it a mandatory to put a 5 millimeter telescope and see your 10 millimeter entry site, and withdraw of a telescope always should be under the vision. I don't like in a suspected cox patient to go in upper abdomen. Invariably in upper abdomen you will find these transverse colon stuck, the loops of intestine stuck in. Now coming to the cox with the fertility, it affects both fertilization as well as implantation. And let's see how we can help. Fertilization, because we know that it causes damage to the tube, it affects the physiological function of the tube. Inner cilia damage, so fertilization part is always in a trouble. And sometimes even if you have some patency where the sperm can enter in, you have an ectopic pregnancy in such woman. Well, alteration in a tubo-ovarian relationship is the problem, and that is where you can't have it because everything is stuck up. You have these flimsy adhesions coming in, and you need to be very, very careful. First examine, see these all adhesions. You don't achieve by doing any adhesiolysis because you know that the entirety of mass is gone. It's unless it's a hydrosulfings, please don't do any dissection here. You within 3 days again the adhesions will be back. These patients need the IVF as the treatment because they have non-functioning tube, or the tube, if at all, it will be prone. But even if you take for a IVF, before you do your frozen embryo transfer, you need to optimize your implantation because affected tube hydrosulfings are not, and if they are connecting to the cavity, they are not going to give you result. So you need to tackle, and there where your endoscopic skills are needed. Endometrial damage or the damage to the cavity is another thing, which now I will go through those videos. Now here, the patient had a bilateral hydrosulfings, embryos were frozen, but here I have tried to take 2 types of videos where one, ureters were engulfed, and in another video where the bowels are engulfed. Now anytime you have this mass completely adherent to the lateral pelvic wall, you can't see anything. Very important, clear your lateral pelvic wall. What I'm doing is I'm sticking out first the complete bowel, the mesentery, the descending colon, cecum, all to be out so that I can go into the retroperitoneal space. You can see the iliac vessels. I'm just trying to enter. You can make out the tissue is little inflammatory. It doesn't open up how with the healthy tissue. And you can see a lot of those flimsy adhesions. Now, once you see that ureter, try to become as less bloody as possible so that the identification is good. Now, sometimes you may have a rare anomaly with the double ureter. So don't think the medial one was the ureter and the lateral is an internal iliac. There is an overhanging hydrosulfings. Try to locate till it disappears into the ureteric tunnel. Now, only when I can see that, then only I should proceed for the hydrosulfings excision. So usually in these women, I try to take out eggs. I freeze the embryos because invariably little bit compromise of the infundibulopelvic ligament, then you may decrease her ovarian reserve. And before you go for the frozen embryo transfer, I usually plan the surgery on 3rd or 4th month of AKT. So, and then we continue 2 months of AKT and then you excise it. Here again, the entry point, instead of from the lateral between the infundibulopelvic ligament to round ligament, I'm directly going from the medial approach because ureter was just in front of me. I'm dissecting down the ureter, keeping it completely safe, and then only. Don't blindly do hydrosulfings excision. You may cause more damage by ureteric damage and then morbidity of fistula formation. So this is very important. Sometimes it is not the ureters. These are the small bowel loops. And look at this. These all patients undergo bowel preparation. That is another problem. We have to do the bowel preparation, but then those loops of bowel become flat down, and sometimes it is difficult. When I can't identify anything, Caesar will be my first instrument than any energy source. I'm trying to see where is the uterus here first. Once I can feel, see, you don't have a tactile sensation, so your instrument work like the probe for you, and you start feeling it. And once you know that this is down, I got the uterus, and these are just the peritoneal folds, and then I can use the harmonic, because harmonic helps in further dissection. Very, very important to fiber by fiber dissection. You need patience. By your small mistake, you can have bowel open up. Now, this is again a flattened out small bowel, so don't cut here. Try to relocate. I'm just going ahead little. What is important is only when you dissect out all, you got these hydrosulfings. Now don't excise here. If you keep this part of a hydrosulfings medial, here I can see the cornu. Very important is dissect down these fibers and reach to the cornu. And this is definitely the hydrosulfings. So your own sonography, mapping, all this is important, and then only you should. Now, unless I excise these hydrosulfings, which are connecting to the uterine cavity, I'm not going to get a success for this. Usually, I don't like clipping. This patient had developed the hydrosulfing because she has a fimbrial block. And if you clip here, you have a complete retort shape dilatation of this segment happening, which may be troublesome in pregnancy. So if you yourself are not a level 4 endoscopic surgeon, no problem. Have a team in your team or team up with the good endoscopic surgeon of your city and do the perfect job. Apart from this hysteroscopy, what is very important is I'm trying to show you various video clips of those. Look at this caseous mass. Unless you clear this caseous tissue, remove these, even after the anti-cox treatment, you will not get it. These are the caseous tissue. You need oxygen to these all. Now, sometimes when you enter in, you find such a pale uterine cavity. Look at this. The amount of caseous mass here, whatever I said and done, I don't think pregnancy is possible in these cases, and you probably better you advise surrogacy to these patients. Sometimes you have only the look at the pale endometrium and the caseous mass all over. You just take a resectoscope without energy source and then remove all these caseous tissue. And sometimes you will find the cavity full of other type of. This is such a pale endometrium, the implantation becomes difficult, but this is distensible cavity. If she has a surplus embryo, I'll remove those caseous mass, I'll remove this flimsy adhesion, and I can think of still going ahead. But look at this caseous tissue. You have to take out this caseous tissue and then only. Now I'm trying to show you, if you try to take out with those rasping, you will find it is so fragile tissue. The entire wall is, you can easily take the resectoscope and take out. This patient was for histopathology. Now sometimes many of our sonologists, we ART consultants say the polyps inside, multiple small polyposis, they are not pathological, but you go in and see the abnormal vasculature and especially in unexplained infertility, this caseous tissue. So don't neglect any polyps. Try to go in a depth and study this patient. Now this is a cavity. Look at this. This is not distensible also and completely frozen. Here the chances even after this, I can show you a beautiful caseous sac formation. Now these are the cases where even if you do the adhesiolysis, it is not going to help you. Look at the caseous tissue collection happening within the wall. You need to drain this out, fine, but these are not the one which is. These are the adhesions where you can think. I'm showing you where these are the flimsy adhesions. And what is important is you don't need a Caesar. I'm just decreasing the flow, but I don't want to put too much of a flow. If I give high pressure, they will break in a fraction of a second, but I will not know the extent of adhesions inside, because even inside adhesions will break and you can see these flimsy adhesion. But otherwise, these are the patient where you can have a little hope and you can think about giving a AKT treatment and frozen embryo transfer in a self. Now, sometimes how it was here, the flimsy adhesions completely at the internal os. Look at here. It is a dense adhesion, very difficult to enter in. And what guides you is the fold of cervical folds. They are the one which will guide you where is the internal os. Look at this. You withdraw your telescope and all the folds are going in this direction. So I'll go. I will never will advise it under laparoscopic control, because your weaken laparoscopy camera, laparoscopy monitor, or your own hysteroscopy monitor. You cannot have diversion of your mind or the eyes. I will go with the guidance of the cervical fold. Take a little bit blunt scissor if at all. Here, because they were so dense, I have to change and take a little sharp, but I'm opening it. I'm trying to open it and see the path of a least resistance, because on a sonography, I was shown that there is a cavity. It means it is just at the internal os. There was some fluid collection also. So I have a hope, and you can see that inside I can start seeing the cavity. And then this cavity, I can then enlarge, I can cut out, and I can proceed it very easily. So this is how you need. So you need to do your own sonography, where you will see that the inside the cavity was there, few flimsy fibers. I will just resect these fibers, and all those adhesions were at the internal os. So your own sonography by yourself helps you to diagnose such cases. Now, sometimes these are the cavity which are of little help. I can see the pink endometrium, and then half of the cavity is gone. So I can just take a blunt scissor. Here I will keep a very high intrauterine pressure, because here I will keep a very good intrauterine pressure, because I just want to be in the center. I am having a little hopes because the rest of the cavity is quite pink. So these are the unilateral adhesion. These are the cases. If they are annular adhesion from all around, they are more dense, they are fibrosed, and those cavities which are not distensible, they are fragile. The uterus is very high chances of a rupture, while these cavity, I will have some hopes. And what is important is, this was a tubular cavity, make it triangular, how you do it in your unicornuate uterus. So here, if cornu is your landmark, internal os is your another landmark. So repeatedly withdrawing the telescope at the internal os, you start thinking about, and you are cutting. I'm all the time, my one eye is at that cornal opening, because cornu are the thinnest. I don't want to go too much inside. Probably this is my lateralmost landmark. Then this is like, it has become a midline septum. I'm going to cut it, and then very small fiber by fiber dissection. Don't overdo, because you can land up in the complication of perforation. These uteri usually are small, and easily this cavity can be perforated. So what I did is, I converted tubular cavity into a triangular, and you put these patients on estrogen, progesterone. Just see, by decreasing the intrauterine up, it means probably regeneration is possible. While these cavities, again, flimsy adhesion, all inside, okay for me. They are not dense. I probably can open up and make the cavity beautiful. Though they are annular, I can, because they were quite flimsy adhesions, and I can think of making the cavity near normal. So, hysteroscopy, friend, the endometrium usually pale, lot of adhesion, difficulty in distension, and Dr. Jyoti Sharma, I wanted to take out your papers because you have huge publication. Increased complications are encountered. Same happens in the laparoscopy, increased complications of all the varieties. But if you are expert, you have an expert in your team, endoscopy is a safe surgery in safe hand. Let's believe in chasing excellence every day. I think endoscopy has given us an opportunity to be innovative, and innovations distinguish between a leader and a follower. What is important is, this is Asherman, just the internal os. I'm just trying to open up. I can see few blood vessels and I can make the cavity. Because I'm endoscopic surgeon also, I can make the cavity. What is the most important question is, can I maintain this cavity? Hardly there is an endometrium. Even if I give estrogen, progesterone, 50-70% of the cavity will be again blocked, and you keep on doing repeated hysteroscopy. Can you think of something novel and mobilizing endometrial stem cells from the bone marrow? And can you think of doing it? The thing which goes in your mind is, can I think of taking out autologous bone marrow therapy, which we do? This is our center where we are doing for many degenerative conditions. We have the experts, GI surgeon, and other people with us, and we can think of doing it. So what is the principle in it is, you take out the bone marrow stem cell, usually from the posterior iliac bone. We take out those and then you isolate them and think of infusing. We do under hysteroscopic. This is nice to show on animation, but we do hysteroscopic under hysteroscopic control, and we do into the subendometrial, maybe 1 or 2 sitting, hoping that we can regenerate it. So around 150 to 200 cc of the bone marrow is extracted, and with the digital non-touch technique, you just extract those. It undergoes several processes, and the stem cells get completely separated. After the sedimentation, centrifugations, and stem cells, 3 compartment happens, and the stem cells get completely separated out. What is important is to get this. Maybe you try everything, but you need to have good trilaminar with the good vascularity. If you don't have this as an end picture, please call it a day, but think of surrogacy, then even your stem cells doesn't give. So friends, what I feel is, you start doing endoscopy, you enter in ART, you do high risk obstetric, and then you realize there are certain cases where still you can't help it, and then you enter into the stem cells and try and finding out. Ovarian regeneration, yes, fantastic, 65% we got the result. Endometrium, sometimes you have to give up, because especially in tuberculosis, if it is an unexplained refractory endometrium, my experience is it beautifully works, because you have a basal endometrium to regenerate. But if you don't have a basal endometrium, if the cavity is completely damaged, then stem cells may not work. But never think you have reached. After climbing a great hill, one finds that there are many more hills to climb, and you are climbing till the end of your life, because you have to see the smiles on so many faces coming to you from across the globe. Thank you so much.
Really excellent talk.
Thank
Thank
you.
you, Dr. Sunita.
Beautiful videos.
All I can say is wow. That was a great
wow.
presentation. It was wow. So all of us are we were all stunned for a little while, and we have reacted now. And thank you very much for that great presentation. I will now go on.
I need to thank you. Thursday night when you said, I said, I never gave a talk on genital tuberculosis. You made me go through few interesting videos, take out the videos, and really it was worth taking out those many exercises. Thank you so much.
Basically, Sunita, it was climbing another hill. It was climbing another hill to see some more. Thank you so much. Thank you very much. And now we go on to Dr. Kuldeep Jain. I have already introduced him to all of you, and I don't have to say that, we all know him so well. And he is now also going to talk about how he is going to optimize, because again, he is a great combination of an ART specialist and an endoscopic surgeon. So let us see how he optimizes his patients when he's doing when he's having a patient of infertility, what he does to that patient. So here are my questions for you, Dr. Kuldeep Jain. How does tuberculosis affect fertility and ART outcome? Which of course many of them have answered, but still we want to hear from you. What are the pre-ART interventions to optimize results? Yeah, this is very, very pertinent. How do you optimize results? What do you do to them before you start with ART? What are the red flags and poor prognostic signs during ART treatment? What tells you this one is not going to go on well? And what are the measures to overcome poor ovarian response and endometrial receptivity? And are there any post-transfer instructions for these patients? So basically, I would stop sharing my screen here, and I'm going to over to Dr. Kuldeep to start with his presentation.
Thank you.
Please do not go away after this because we have so many questions for all of you. There's a big list. I have extended the time to all of you. Let me tell you, I have extended the time. So please, Sunita, everyone, please don't go away. We have too many questions. And I think we should answer all.
Thank you, Dr. Sonia. I must congratulate Dr. Sonia, actually. And this is my time to thank Dr. Sonia, because this is the concept which we made together, and she really helped me in choosing the right person for this program, because that was very important. If we are not able to give the way I wanted to give or she wanted to give, then it would have been not very useful. So I am very happy, and I really extend my gratitude to Dr. Sonia Malik, who has actually really worked in tandem with me for last 15-20 days to finalize the program, how it should go, and who should be the people we should involve. And I am really thankful that we have done what we wanted to do in this program. So thank you again.
Once again, let me just ask everybody to vote and support our friend Dr. Kuldeep Jain for his candidature for North Zone Vice President.
Thank you so much. So, genital tuberculosis, ART, my way to optimize. I think everybody has already discussed a lot of things. Maybe there may be little repetition, but everybody is having their own way, and I will like to share my experience in these patients. Dr. Sunita has already highlighted what are the problems with the tubes, what is the problem with endometrium, and there is one more thing. Whenever we talk of tuberculosis, we always talk of tubes and endometrium. But I think we forget ovaries, and ovaries equally affected in genital tuberculosis, and I am having a lot of data to support that thing, that ovarian response, and as well as the egg quality and embryo quality, whatever we get, is compromised in genital tuberculosis. I don't have anything to disclose here. This is already highlighted in all the talks, and when it comes to the pregnancy, many of the patients, their only hope is ART. But when we come to ART results, of course, these are little older paper. We have moved ahead. This is from Dr. S.N. Tripathi. And let me tell you very frankly, whatever literature is coming on the genital tuberculosis, almost 60 to 70% is from India. We need to search the literature. It is there. And we should take the cue from all available literature and try to use it in our practice. So if you see here, this is 2002 data. Conception rate is quite low when you compare from non-genital tuberculosis cases. This is again Dr. Sonia Malik's paper in 2010, and she has also said that whatever you do in genital tuberculosis, the per transfer rate remains quite low at 16.6%. So these are some of the questions I am going to answer. Burden, I will not go again. This is Dr. J.V. Sharma's paper, and it is all across globe. It is not only India or Africa. Even in USA, you have genital tuberculosis. Effect of genital tuberculosis on fertility, endometrium is affected, tubes are affected, and ovaries are affected. So endometrium, this is again J.B. Sarma's paper, and most of the work is coming from Dr. J.B. Sarma. So I must congratulate him for continuing actually searching for the evidences. So please keep it up because you are having the resources, you are having a research setting, and you can really add a lot of data for helping each and every one of us. And even out of India, people are looking at your papers. So you can see it is defective endometrium receptivity, poor embryonic implantation, and endometrial atrophy and Seneca formation in almost all cases. It could be grade 1 to grade 4, but in almost all cases, you will be having some involvement of endometrium. These are very classical pictures when it comes to the endometrial involvement. And when you put the scope, you can find these type of adhesions, or maybe Esserman grade 4, where you are not having anything. When you put the scope, you find only 10% of the cavity, and most of these patients, they are having either very, very scanty periods or amenorrhea. What you want to see at the end of your adhesiolysis, that is very important. Dr. Sunita has already highlighted. Whenever you are doing histoscopic adhesiolysis, at least 70 to 80% of the cavity should be available at the end of your dissection. And it is always better if you are able to see one ostia. So you may not be able to see both ostia, but if you are able to see one ostia, it means that you have at least reached up to a certain extent, and that you can use for implantation. That cavity can be used for implantation. Coming on to fallopian tubes, again, almost 90% of the women, they are affected, their fallopian tubes are affected. Again, unilateral or bilateral hydrosalpinx, and this all is already highlighted. Again, this is paper of J.B. Sarma only. And these are the diagnostic features we have to take. Actually, we have already discussed the diagnosis. So current recommendation for clinical practice is before starting a ATT treatment, you should have at least one clinical and one lab diagnosis in your hand to be on safer side to avoid any drug resistance in these cases. And you see the mucosal damage, endosalpingitis, exosalpingitis, all are there. Coming on to ovary, this is not touched actually, so I will go into little detail here. And this is again Dr. Neena Malhotra from AIIMS. She has studied the effect of genital tuberculosis on ovary, and here you can see there could be defective ovarian function. Anovulation is there. There is a high day 3 FSH and relatively low E2. We require more ampule of gonadotropin in IVF cycle in genital tuberculosis. That is, we all have experienced. And then there is luteal phase defect also in these patients. Implantation failure, then that leads to the lower pregnancy rate and high miscarriage rate. And as far as the embryo quality is concerned, again, because of the intrinsic oocyte factor defect, there is poor embryo quality. So in her paper, Dr. Neena Malhotra in 2012, mean FSH and LH was higher, mean inhibin was significantly lower. The ovarian volume, antral follicle count was significantly lower in genital tuberculosis. And what she concluded that ovarian reserve was compromised in women with genital tuberculosis. Coming on to what are pre-ART intervention to optimize outcome, we are having intervention which is already highlighted. I will also like, because I do a lot of endoscopy and I am having again a large series of genital tuberculosis to work on in last 20-25 years. Endoscopy is really a good tool to help in these patients, whether it is hydrosalpinx, you have to treat hydrosalpingo before you go on to the ART, so to optimize your ART outcome. Second thing is endometrial correction. All these patients, they do require some form of histoscopic correction to enhance your ART outcome. So when you are having a genital tuberculosis patient, even if you are having a endometrium which is looking good at ultrasound, but when you put a scope, you will always see some subtle defect in genital tuberculosis cases, whether it could be a focal atrophy or a focal congestion or micro adhesions, and that actually spectrum goes on till you see a Esserman grade 4 endometrium. So a full spectrum is available in genital tuberculosis. It is until unless you see directly with histoscope, you will not be able to actually collaborate that what is the effect of genital tuberculosis on endometrium. This is a video of genital tuberculosis patient. This patient actually had on HSG, her tubes were patent, but when you put the histoscope inside the cavity, you find that whole of the cavity was having multiple adhesions, and these adhesions actually are very easily correctable if you are able to see the cavity, the normal cavity beyond these adhesions. And as Dr. Sunita has rightly highlighted, until unless you do your ultrasonography yourself, you may not be able to really help these patients. So it is very important when you are having an infertility practice, you have to learn your ultrasound very judiciously. And of course, if you are able to operate yourself, then it becomes really wonderful to provide or to optimize your ART results. So if you are having a combination of ultrasound, endoscopy, as well as the ART, then these patients, they certainly can be helped in getting the pregnancy. If you see at the end, when I started, usually the endometrium is looking pale because of the adhesions, and once the adhesions are released, you can see a nice endometrium at the end of the procedure. Usually the lateral wall is also adherent, and we usually try to avoid using any current in this type of surgery. But on the lateral side, dissection with microcissure may be little difficult, so you can use a very mild current to open up on the lateral side. So at the end of the surgery, you can see very nice cavity here, having a good vascularity. So that is what is required. This is a patient of Esserman grade 4. When we entered, you can see there is no cavity here. Only 10 to 15% cavity was available, and only this area was available where we could have started the dissection. Now this patient is again, until unless you know that there is a cavity beyond it, you cannot proceed ahead. So transvaginal ultrasonography preoperatively and transabdominal ultrasonography during the surgery is very helpful in these cases. And as Dr. Sunita has already highlighted, that you have to have patience. Whenever you are doing this type of surgery, you have to just open your blade, try to get into the right plane, and keep on doing the dissection till you get at least 70 to 80% of the cavity to work on. Many of the time, these patients, they require a second look or third look histoscopy. So it is always good to counsel these patients beforehand that whatever you are doing may not be sufficient for implantation, and it will depend on the regeneration, because until unless it regenerates, it may not be able to, you may not be able to help you. Here you see it, this is a large caseous chunk which was here, and this was quite hard here, and you have to dissect out before proceeding ahead. So this was a proven case of tuberculosis, received anti-tubercular treatment. Again, in this patient, we had to go for histoscopy 3 times before we implanted the embryo. And this patient conceived, but aborted once, and then in the next attempt, she could take it. So you can see a large chunk of caseous material here. And you see at the end of the procedure, I am able to get a cavity which looks quite promising. All these patients, they need to be supplemented with estrogen valerate for a longer period, maybe 6 to 8 weeks. Without that, you cannot go ahead. And the follow-up, whatever follow-up is required, it is by ultrasound. You have to do monitor the regeneration by ultrasound and color Doppler to see whether you can go ahead for implantation or not. So this is the final result. You can see the cavity is quite satisfactory, and you can see the one ostia here and other ostia here. There are few adhesions on the lateral side, so they can be again dissected to get a more wider cavity. So I think this is the one of the procedure intervention which really help in these patients. And many of the patients, they can get a pregnancy after doing the intervention. Another intervention which is required to optimize your results is either you do the self-injectomy or the delinking to optimize your pregnancy result in ART. This is one paper just showing that what is the influence of self-injectomy on IVF outcome. And here you can see this is the self-injectomy group, and this is no intervention. So it is very clear, if you see the cumulative pregnancy rate, they are significantly different in self-injectomy group. So this is one intervention which actually gives a quite good success rate in ART once you do that. Now, another question was, what are the red flag signs or poor prognostic signs during ART treatment? Again, poor response to stimulation. This is a red flag sign whenever you are giving the stimulation. If you are not seeing the good response, then these patients, they are having poor prognosis. Though you may have the embryos in hand, but usually when we compare, if a good response patient of female genital tuberculosis compared to a poor response, the prognosis in these patients is poor. So because that shows the amount of disease which is affected the genital system, whether it is ovary or endometrium for that matter. So poor embryo quality, whenever you are getting a poor embryo quality, again, it is not a very good prognostic sign, and you may have to go for egg donor program in these cases if you are having very poor quality of embryo. Poor endometrial growth in spite of extensive additional. You have done everything, but if your endometrium is not growing, I think that is the time when you look for the surrogacy, until unless you are having stem cell proven result. So we need to really work on the stem cell area to avoid surrogacy in these patients. Otherwise, the prognosis remains poor even after doing extensive additional. And after additional, if you are seeing poor Doppler indices, because many of these patients, they will have a good endometrium at the end, but if the Doppler indices are not good, This is actually, when we compare the Doppler indices in non-genital cases, they are not very well correlated. But when we see the Doppler indices in genital tuberculosis, they are quite correlated with the poor prognostic criteria. So again, these are some of the papers from India only. Poor results with IVF in genital tuberculosis. We need more gonadotropin, and you have to start with high gonadotropin dose. So in the same age group, you will require more gonadotropin, and you have to start with high dose. Oocyte and embryo quality is poor, and pregnancy rates are poor. This is our experience of genital tuberculosis. We actually had 151 cases in this series. Histoscopy was done in all cases. Adhesiolysis was done in by histoscopy. But we studied the ovarian response and endometrial response, fertilization rate, and ongoing pregnancy rate. And here you can see endometrial response was quite good after the histoscopic resection. So in those cases where the extensive adhesiolysis was not required, where you had a mild disease, the endometrial response was better. But even in those cases where you were not having a good cavity, only 5 to 7% patients had less than 7 millimeter after histoscopic adhesiolysis. So histoscopic adhesiolysis is certainly one intervention which really works in these cases. When it comes to ovarian response, you can see more than 30% patients had poor ovarian response, having less than 8 follicle. And if you see the fertilization rate, again, it is quite compromised when you compare to non-genital cases. But the cumulative pregnancy rate in this series was quite good if you compare with the other reports. And I think we need to have more data. If we can get a pregnancy rate of 35% plus, then it is worth doing histoscopy and other intervention in these patients. This is again a paper from Dr. Nina, who has shown that there is a decrease in the perifollicular blood flow in these patients. This is a paper from my institution, and here you can see we have studied the oocyte quality in ICSI cycles in genital tuberculosis. All parameters are affected, whether it is AMH, M2 yield, grade A embryo, or pregnancy rate or fertilization rate. And these three criteria were actually significantly different in genital tuberculosis. So what we concluded here, ICSI cycles in patients with positive history of genital tuberculosis is always associated with low AMH, lesser M2 retrieval, less grade A embryo, and less fertilization rate. So this was our observation, and this is another paper in fertility sterility from our center. And here again you can see all parameters, whether it is AMH, AFC, or the fertilization rate or pregnancy rate, they are all compromised in these cases. So what we concluded in this paper, genital tuberculosis affects all parts of genital tract, including tube, endometrial cavity, and ovarian reserve. And we see poor ovarian response, compromised egg quality, and poor fertilization rate. But histoscopy can improve the outcome if done in these cases. So that is one intervention which we find really helpful in improving the results. This is a paper from Dr. Sonia Malik, again 120 cases, pregnancy rate 38.2%, comparable to other indications. So if these patients, they are taken, followed properly, I think we can really help them in getting a good success rate. What about GCSF and PRP? This is again after histoscopy. So this is another intervention which we have been doing in these patients. Whether you use GCSF or PRP, it is helpful in those cases where you are correcting the defect. So if you are correcting the defect and then using the GCSF and PRP, certainly it is helpful in some of the patients. Like in this series, you can see 30% had more than one IVF ICSI failure, 12 conceived after GCSF therapy and hysteroscopy. So even in those patients where the previous cycles have failed, you can offer the hysteroscopic adenolysis followed by GCSF and PRP, and these patients, they can be helped. So what are the intervention during ART? We usually now switched on to PRP rather than GCSF, because we had a paper, the thesis paper, and there we found that comparing GCSF and PRP, PRP was much better in giving a better blood flow. Proliferation was almost same in both the group, but the blood flow indices was better in PRP, and finally the vascularity and implantation rate were better in the PRP group. So last question is post-transfer instruction. Nothing specific, but we use estrogen supplementation along with progesterone in all these cases, and that gives a better outcome in these patients. We need to continue all the support till 12 weeks of conception, and of course good counseling is what is required, because the patient is coming with a lot of hope. So you have to give a positive counseling, but keeping in mind the limitation. So that is how you have to counsel these patients, and it is always after hysteroscopic adenolysis, you have to tell the patient that the option of surrogacy is always there. So with that type of counseling, you can take these patients to help in getting a conception. So summing up my talk, female genital tuberculosis is important cause of infertility, and it is really responsible for more than 50% of the cases in some of the studies. Female genital tuberculosis can cause destruction of ovary, few ovarian masses are there, poor quality of response is there, poor quality embryos, and they usually need high doses of gonadotropin. Variable presentation is there, and you have to plan your program in such a way that at each stage you are able to help in getting a better quality cavity and better quality embryo. Minimal role of surgery, but whenever we require surgery, it is quite helpful. So you have to select your patient for surgery, which patient will have benefit of your surgery. Hysteroscopy is again very important tool to evaluate and correct the endometrial defect. ART gives best result, and there is role of gestational surrogacy in these patients. So that is the final thing that you should know when these patients they should be offered surrogacy, and you have to stop ART treatment, putting the embryo in the same cavity when you are failing again and again. So thank you very much for your kind attention. Over to Dr. Sonia.
Thank you, Dr. Kuldeep, for a brilliant presentation. It was a great summary of endoscopy as well as ART. And I'm quickly going to share my screen, give you a little take-home points, and then go on to a million questions that we have.
And
really excellent talk,
before you start, I will like to share the report from Sana. We had 850 plus login for this program.
Excellent talk, Kuldeep.
Thank you.
900, latest she has written 900.
Yeah. Before my talk, it was 850, so people are still logging. So thank you very much, everyone, for logging in this program.
Thank you so much, everybody, and thank you for staying with us till the end. We are still not over.
Yeah.
Thank you so much. I'm sorry. Just a minute. Just let me go back to my screen. Screen sharing. God, where is this screen? I just wanted to share, and here it is. Sorry. Yeah.
Hello.
Sum up then. Sum up what we heard just now.
Yeah.
Clinically,
I will,
as Dr.
you are there. I will just
only
invite you
suspect,
to say a few
unless there
words.
are gross changes in the reproductive tract. Tests are many, but gold standard is demonstrating the
Dr. Sonia,
tissue.
Dr.
The
Sonia,
expert in that may help, but with other signs and symptoms, not all by themselves.
Dr. Sonia, can I interrupt? Can I interrupt?
Yes. Yes.
Dr. Mandakini Meg has joined. She is waiting for quite some time.
I
So
will
I welcome.
take her in just now.
I welcome her on the program.
I welcome her.
Dr. Mandakini.
For us. Give me a minute and I will after just
Yeah, please.
Endoscopy complements ART when we treat infertility in these patients, which both Sunita and Dr. Kuldeep has said. They are both great endoscopic surgeons and we've seen fantastic surgery. Pregnancy is high risk and needs careful monitoring. ATT is safe and must be given in pregnancy if it is required. New treatment guidelines of the Government of India must be followed. These are the guidelines that we draw from this whole symposium, and I'm just going to go through the new guidelines because everybody must know them. The National Tuberculosis Elimination Program is the new name for this program, and the initial intensive phase consists of 8 weeks of 4 drugs and continuation phase of 3 drugs of the same 3 drugs, and alternatively written as 2 HREZ versus 4 HRE, which we were told. And the drug dosages must be given according to the body weight of the patient. There are 4 weight band categories. All patients must receive their doses daily. This is a change. So under this, we will be giving fixed dose combinations to these because instead of the 3-4 drugs in specific dosage, 1 pill or 2 pills are easy to take. So the patient will be consuming only 2-3 tablets a day. This is according to the senior officials. And this is a beautiful app which they have developed, wherein you can log on and which you can follow and go on to the website and give it the details of the patient and notify your patient. This is available and this is a common program which is called JOINT, which JEET. This is a joint effort for elimination of tuberculosis, which is being, this is a NGO which is helping to eradicate tuberculosis in the country, and they are helping at each step. So in every district in the country, whether it is Delhi or anywhere else, you will find these workers, these JEET workers, who will be helping you out, not only to notify the program, getting your patients the drugs free of cost and registering them with the Government of India, and also offering them money, because Nischay enables direct benefit transfer of incentives given to the patients and their beneficiaries under various schemes. There is a Nischay Poshan Yojana for a TB patient also, and HIV is also reported along with that. So with that, now I'm coming to the questions. And please, just a minute, let me just stop sharing my screen and getting all my panelists here. So basically,
Dr. Sonia, you can invite Dr.
First,
Mandakini.
Madam, please welcome Dr. Mandakini. It is such an honor for us to have you here with us.
Thank you very much. First of all, my apologies that I am joining. I am becoming the guest of honor for the closing ceremony. So that is a new trend because there are so many simultaneous webinars are going and you are talking. So I thought I must meet you all people because you have decided a very, very important national program, tuberculosis, and that too in IVF and reproduction is a very, very important topic. So I congratulate AOGD, Dr. Sonia Malik, Dr. Kuldeep Jain, Dr. J.B. Sharma, Dr. Namda Nagar for inviting me to this very, very great program. I thought I should have been there, but I don't mind because Dr. Sonia, Dr. Sunita, I keep on meeting them. They are my regular faculty for the ICOG. So thank you very much. And I just want to inform you that at ICOG, I take this opportunity to inform all 900 people who are logged in that we are open for the FICOG fellowship. And this first time the FICOG fellowship is online. You can download from the website and you can apply online. So there is no documentation required, only online application. That is the first thing. And second thing is MRCOG exams who are giving from Delhi. That exams are online and that is link has been given in the website of ICOG. So you please download because it will be all conducted from the RCOG college. So there will be no physical examination in India. So that is very second important thing. And I appreciate that. Suppose this is a very national important program. If we can do any kind of certificate course, Sonia, you know that we have been doing Nirja also knows oncology course. So we ICUG will be, very appreciative if you can do some kind of ICUG course for this very, very important national program. So with this, uh, I think excellent talk by Sunita, by Kuldeep, and wonderful. And I thought tuberculosis is only meant for us government people because we see and all the time tubercular patient and infertile patient, and we don't know what to do. Now we know where to send the patients. So thank you very much for inviting me, and it's a great honor and pleasure to come here. Thank you and good night.
Thank you, Dr. Mandakini, for joining and giving us some words of encouragement. It is really wonderful to see you here. Thank you very much.
Thank
Dr.
you, and
Sonia,
thank
we
you
can
for your
continue.
thank you for that vigorous Josh that you always have. Always pushing
encouragement.
Yes.
Dr. Gujral, the questions are mainly for you because they pertain to the diagnosis, and of course Dr. J.B. Sharma will pitch in. So then again, the first question is of course quite standard, but it is, what is the gold standard test for diagnosing genital? one word.
Gold standard is
I think all of you can answer this.
Well, gold standard is getting the bacteria culture.
Getting the culture.
Yeah.
So, Tita, getting the culture?
Yes, and the histopathology as well.
And Dr. JB, what is the gold standard? You are the master.
The gold standard remains a demonstration of the bacillus, or now histopath, or now PCR, this gene expert also. Okay, but if you depend on these three tests only, you will pick up only 20% cases, 20 to 25, so you will miss 75% cases. So that's why this composite reference standard has been now documented, and that is used for pleural tuberculosis, other extrapulmonary tuberculosis, even for typhoid and other diseases. It's not only for tuberculosis. In composite reference standard, we take 5 things: either AFB microscopy positive, AFB culture positive, histopath positive, or gene expert positive. Plus, we take laparoscopy also. So, positive finding of laparoscopy, that means definite finding of laparoscopy of tuberculosis on laparoscopy, which means this granuloma, cages, nodule, this beaded tubes, and tubercle. These are definite finding, or probable finding of tuberculosis on laparoscopy, like hydrosalpinx, pyosalpinx, teomasis, this encystic ascites, peritubal, peritoneal, abdominal, other adhesions. So
And
these
all
are
your
the
signs and all your signs.
So if you combine the 5 things, that means we call it composite reference standard. Then we can pick up more cases.
Okay.
But they will be probable to.
JB, what is the place of man-2 test now in the current?
Thank you. Welcome, madam. Thank you. Sorry, I couldn't talk to her. And sorry, madam. What, sir?
Do you still get a man-2 test done at all?
No, man-2 test actually. It is being done as a part. Medicine people often refer them. So, but it may help you a little bit, but neither diagnose you nor exclude tuberculosis. So it should not be.
You can get away with
I think now in the current COVID era, particularly, I don't know, you give it one day, then you call them back for the reading. So I think we should give a clear message that now we should not consider doing this anymore.
Yeah, we did say that, Nisha, that we.
Yeah.
We used in clinical practice.
And so,
That's it.
Anyway,
Totally.
question for Sunita. Hysteroscopy shows patchy strawberry lesions in the endometrium. Both the tubes are sacculated. Dr. Kuldeep, you can also take this.
Yeah.
Both tubes are sacculated. There is fimbrial phimosis, but on chromoperturbation, both the tubes are patent. But the tubes show prominent microvasculature. Should we start ATT? This is from Dr. Deblina Bhaumik. So, patchy strawberry lesion in the endometrium, both tubes sacculated, fimbrial phimosis, but patent, and they show microvasculature, which is prominent.
see fimbrial phimosis, but patent tube, because though it is a phimosis, may be small leakage, and that's why HSG is showing the patency tube. Patent tube doesn't mean they are functioning tube. One has to be very, very clear. So,
give ATT or not?
Huh?
Will you give ATT or not?
What I will do in this case is, Dr. J.B. Sharma has made it very clear. Take an endometrial fluid, send it for cytology, send it for AFP culture, do the histopathology, gene expert. Also, in laparoscopy, do the extensive survey even to see the subdiaphragmatic region. And take the peritoneal, whatever the vascular tissue they are saying, take the biopsy of that also. While taking a biopsy, take it with the Caesar, and because it is a smaller peritoneal tissue you will be taking, don't use a cautery because you will burn out and the histopathologist won't be able to take. So just take a peritoneal fold, take it with the Caesar and send it for also. If possible, take a peritoneal fluid also for the AFP culture. So all these things I will do. In today's day, when the government is making it so strict that you cannot start empirical line of treatment for AKT, I won't suggest anyone to start without the proof in hand.
Dr. Kuldeep, your take on the same case?
Yeah. I think Dr. Sunita has already highlighted just by looking at because that is suggestive of tuberculosis. But as far as the starting of the treatment is concerned, we need to do a histopathology sampling for histopathology, AFB culture, as well as for gene expert. And try to find so try to find out the more proof of genital tuberculosis, and it is always better when you have one clinical and one lab, so you are very sure that you are starting the ATT in right patient.
Dr. Your final take on this.
Yeah, 1 minute.
You said laparoscopy is also now included in the testing.
No.
So now tell me, these are the laparoscopic findings. Will you put the patient on ATT or will you do some more tests? All 5 or just 1? Dr. JB, can you hear me?
Yeah, madam. Basically, like that's the whole purpose, madam. I mean, this gives you ammunition. Nobody can sue you. I mean, there have been, I have heard some doctors have been sued for starting ATT unnecessarily. But as a doctor, as a clinician, I mean, when I have done laparoscopy, so I know that, yeah, there are tuberculosis findings. So I will document in the notes like finding tuberculosis finding on laparoscopy seen, diagnosis genital tuberculosis on laparoscopic finding. And I write them ATT, refer them to my dot center. Sometimes they do send the bed, but I put my stamp and signature, then they have to give ATT. And that will safeguard my test also in the court in case goes to the court. Yes, I had seen finding of tuberculosis on laparoscopy. But if you see, I mean, just
these findings on laparoscopy are enough, even without sending the tests for histopathology, etc., or all of them, and
no, but I think nobody is stopping you sending the sample because you are doing a laparoscopy. That is the normal protocol. Whenever you are doing a histolaparoscopy, you have to send the material for sampling for all 3 histopathology, AFB culture, as well as the gene expert. So you are more sure that if you are starting ATT,
tests have to be sent. Tests have to be sent, man. There is no doubt about that.
Dr. 1 minute. What is the real challenge and the discussion come is you have sent all that and it has come negative.
Yes.
You have a laparoscopic evidence with your these things.
Yes, then you can,
Then it's important that you write your notes and use my experience. So that tumhara sikka, tumhara signature and referring is important.
Yes.
Very, very important message that is emerging now, that if you have these laparoscopic findings and if your other tests are negative, you can still get away if you have written your notes properly, and they are suggesting tuberculosis. So,
madam, and like in medicine also, no, if you allow me, in medicine also, empirical antitubercular treatment has always been allowed. Okay, so what we can do here to safeguard our interest? I mean, many times from clinically, madam, like at our level, at your level, you know that this patient has got tuberculosis even without doing anything. Like patient is thin built, patient has got oligomenorrhea, hypomenorrhea, there has been a family history, and all tests are coming negative. In that case, just put a laparoscope in, and then you can, like nobody is going to record your, recording of that. You can write, findings of tuberculosis seen, some finding will always be there.
This is a very welcome change in the thought process of the government, that they are allowing us to start ATT on the basis of laparoscopic and hysteroscopic.
Absolutely, madam.
The thing is,
Sharma, can I ask you one question? Suppose clinically I feel patient is exposed or husband is on anticox, loss of weight, appetite, evening rise, but the reports are negative. Is it mandatory for me to do laparoscopy, or I still can only on a clinical? See, laparoscopy, you are putting one patient for a surgery. You are expecting you can have an intestinal adhesions inside, you can have a complication. You yourself have published that laparoscopy. So
absolutely.
For diagnosis, am I supposed to do the invasive surgery or on other parameter, including raised ESR and leukocytosis and anemia? Can I give ATT?
But that is a bit dodgy question. But basically, certainly, if you you need to have some evidence actually. In that case, maybe only on the basis of PCR. With all these findings,
I'm asking government guidelines. Whether the government guidelines allows me?
No.
Without
you can strong clinical suspicion. Strong clinical suspicion you can write.
Okay.
It allows you to go ahead and test, because then it is a presumptive or a suspicious case. In order to turn it into a definitive case, you will have to do tests. That is what it means actually. So therefore,
get you what I'm supposed to do.
There is a second question which is very similar to what you have said. Unilateral testicular epididymoarchitis in a 12-year-old child whose father is taking ATT. Are we supposed to give how are we supposed to test and how are we supposed to give? So let us keep that. I'm not taking this question, but I'm saying that somebody, Dr. Suresh, has asked this question. But what I would like to ask all of you is, Dr. Kuldeep, maybe you could take this one. If patient is not able to tolerate first-line ATT due to hepatogastrointestinal symptoms, then how long and what second-line drugs will be given to her? How long should you give, and what are you going to give to this patient? She cannot tolerate first-line. Rifampicin is absolutely horrible for her, or her LFT is deranged.
Yeah, I think Dr. Narendra has already highlighted this point. When there is a drug resistance or the patient cannot tolerate, you have to start the alternative treatment. And when you are starting alternative treatment,
how long?
See, primary, it will depend on at what point of time it was discontinued.
Probably very early.
Probably very early. So the complete 6 months is required in genital tuberculosis.
Any change, Dr. JB, or do you agree with this?
Yeah. Madam, I'll tell you actual practical case. This was my relative patient. So that's what also I want to highlight. All of us keep writing LFT. Please don't get unnecessary LFT. The reason being that, whenever you start ATT, the LFT will increase by about 3-fold. Yes. In fact, if in a case LFT does not rise at all, so your ATT is fake. So some ATT rise has to be there.
Everybody attending.
So this is very important. Up to if they rise more than 5 times, that if the level of LFT rise 200 or more, then only they are suspicious. So don't get unnecessary LFT done. And I had this patient, she had such severe hepatitis, and then what to do? So, she had pulmonary, the pleural TB, of course, not any. So, but ultimately they stopped all ATT because rifampicin, isoniazid, paraginamide, all the 3 are hepatotoxic. So all the 3 drugs were stopped, only ethambutol was continued from that, plus she was started levofloxacin high dose. But then within 2 weeks, she was admitted also, given a IV fluid. And then gradually, so she was given levofloxacin, then they started one drug. Okay, I think rifampicin was added. Then after 1 week, they added the second drug, isoniazid. Then they added the paraginamide. And ultimately, within 4 to 6 weeks, she could start all the 3 drugs or primary drugs. So that if someone starts hepatotoxicity does not mean that the drugs are gone forever. So ultimately, after 6 weeks, she could continue all the 4 drugs, and then gradually levofloxacin was stopped. But then that 6 weeks treatment was not counted. You understand? So ultimately, I mean, after 6 weeks, she could restart all the 4 drugs, and then they continued. Professor Randeep Guleria, I mean, I was in touch with that patient. So that this treatment was not counted. So what I mean, if someone develops hepatotoxicity with the primary drug, doesn't mean that she can never take those drugs. Gradually, but you have to stop at that time because it can cause even death. You know, this hepatotoxicity is very serious condition. So then she was given only ethambutol, which is the safest drug out of the 4, and plus levofloxacin, and I think one more drug I have forgotten. And then gradually, then ultimately levofloxacin was stopped, and she was restarted one of these drugs, primary drug. And after 6 weeks, she could take all the 4 drugs.
I
So
think when you have a patient like this, the message is that if you have a patient like this, we should consult our physician friends
Absolutely,
and
absolutely.
not keep on treating them ourselves, because it means
Yes,
there
yes.
needs to be a lot of follow-ups and a lot of control.
Absolutely.
Gujarat wants to say a word. Wants to say a word.
1 minute. Do you recommend them to do LFT? I thought no is the answer. Do you recommend
Don't do LFT unless patient has got lack of appetite or hepatotoxicity symptom.
So the message should be
Otherwise,
that
the level will come level comes 170. What will you do?
Exactly. That's what I want.
They should come up to 200. No,
These are 3 questions which are related to each other. These are again 3 questions related to each other. And Dr. Isha is asking these questions. If HSG suggests features of genital tuberculosis, but she has a good trilaminar endometrium, is laparoscopy indicated? And what is the role of EB in that case? Number 1. And in the same breath, she's also asking, the tube is beaded on HSG, but there is no hydrosalpinx. Is this an indication for clipping before proceeding for IVF? Now, Sanita.
Okay, so first thing is HSG.
No hydrosalpinx. Second is hydrosalpinx, but trilaminar endometrium.
So first of all, most important thing is don't just believe on HSG finding that the tubes are beaded or anything. Remember, in HSG, the dye is pushed. Patient can have a spasm. There can be a peristaltic wave. It can be falsely represented. Now, if it has caused so much of a tuberculous sulfingitis that it has caused the changes, it will definitely will have a tuberculous endometritis element as well. Laparohysteroscopy and evaluation is always needed for this.
So then hydrosalpinx is there, but she has a trilaminar endometrium. Dr. Kuldeep, what will you do?
Yeah, so see, if it is a visible hydrosalpinx on ultrasound, it needs to be clipped. If you are seeing a hydrosalpinx on HSG, I don't think that is a true hydrosalpinx, because you are pushing the dye in the tube, and if there is a phimosis at the femoral end, it is going to form the hydrosalpinx. So until unless you are seeing a visible hydrosalpinx on ultrasound in these patients, there is no need to clip.
And so, Dr. Sharma asking you a laparoscopy question rather than treatment question.
Yes,
what is the cutoff for diameter of the tube for salpingectomy in hydrosalpinx? Dr. Deshmukh is asking, would you do salpingectomy or you just open the hydrosalpinx? What is the cutoff for hydrosalpinx?
I think Kuldeep can answer it better, because there have been some studies that if you the hydrosalpinx fluid I don't do IVF myself, but it inhibits, I think, IVF results. Hydrosalpinx fluid. So there have been studies that removing the tube helps. But I think Kuldeep can answer better. Probably mild hydrosalpinx.
So will you do, Dr. Kuldeep, will you do a salpingectomy in all the cases, or can you open
corrective surgery in genital tuberculosis is not recommended, and we don't do. So there is no corrective surgery, because even if you do corrective surgery, because previously when we were not doing lot of IVF, maybe 20 years back, then we were doing a lot of corrective surgery. Okay, but once the IVF came into picture, we have stopped doing corrective surgeries, because there are more chances of the prolongation of the infertility as well. Because once you do the surgery, the patient will wait for 6 months, 1 year, 2 years, and if they conceive, usually it ends up into the ectopic pregnancy. So
Sunita, now for you, that is clear. Sunita, now for you, if you are going to do a corrective, so if you are going to do a salpingectomy, are you going to put the patient on ATT before or after?
Okay, this is a fantastic question. Usually, I take out the eggs first, I freeze the embryos. And then, ideally, if I have diagnosed this patient, even while taking them for a stimulation and all, she is on AKT the moment we diagnosed it. I removed it, and once her ovaries, which are usually swollen and all, I allow 1 month to go with the OC pills, because you have just retrieved the eggs. I will not do anything in that month, but her AKT goes on, and 3rd month of this thing. Even for the transfer, I don't wait till 6 months or 9 months of AKT treatment. Usually with 3 months of a coverage, on a 4th month, I do the frozen embryo transfer.
Okay. Dr. Kuldeep, what is your practice?
Yeah, same year, 4 months of ATT, and then we can use the cycle for transfer.
No, but what about hydrosalpinx and?
No, if the patient has already taken ATT, usually I don't start ATT until unless there is some suggestion of active tuberculosis. Like in culture, if it is coming positive again, then they require a repeat therapy. Otherwise, you don't give repeat therapy.
Okay.
Can I say here, madam? Yeah. And this is important because PCR don't depend on PCR. PCR may remain positive throughout life.
Yeah, it is culture.
That
is culture. Yeah.
Second thing about salpingectomy, Dr. Kuldeep, if you allow me, I had 3 doctors, talking to me. They had court cases. One doctor in Dubai or somewhere. She did the salpingectomy for hydrosalpinx, and then the patient sued her. Another doctor in Kolkata, big name, I won't name. Again, there was a case against him that he did salpingectomy and the patient didn't like it and she sued the doctor. So he wanted me to help him in, giving the document. So please, whenever someone is doing salpingectomy on hydrosalpinx for these patients, because then the patient thinks that I might tube has been removed, and I could have probably. So it should be proper counseling has to be done on.
Yes, very important. Proper counseling and consent.
How long do you have to continue treatment is the next question. And what retesting will you do to find out whether the disease is gone or not? Dr. Kamal, how long are you going to give the treatment, and what retesting will you do to know whether the treatment is good or not?
Has to be cured or not. That's all. 6 months treatment has to be given. There's no question of 2 months, 3 months, or a small treatment.
6 months treatment is enough. Okay.
What Dr. Sunita had said, my take as a person looking after high-risk pregnancy is that you have your frozen embryos. They're not going to die. Why don't you complete the treatment to the AT? Rather than letting her carry those drugs. We know they are safe, but still they are in the first trimester. That's
okay. Yeah. That is okay. But what test are you going to advise? What are you going to retest, or you're not going to retest?
No, I don't think I'm going to retest.
You don't retest. No, Dr. Sunita, are you going to retest before you do an embryo transfer after giving 6 months of therapy?
No need of retesting.
No need of retesting. Dr. Kuldeep?
No need.
Hysteroscopies before she became pregnant. That means she did have disease. She kept on getting adhesions. So will you retest or you won't retest?
No retest.
No retest.
Actually,
no retest.
But if you allow me,
Dr. Devi.
See that she has become seronegative. What they mean is that is not needed. But if she had a hysteroscopy, which she had adhesions, you always will do the second look hysteroscopy before transfer. Now to Dr. Gujral, it is so easy to say wait for 6 months, wait for 9 months. You try to understand and sit on another side of a table. Yeah. They are anxious. Second thing is the number of eggs, number of embryos, and implantation rate is so less in this. So it's not that you are going to give, even if she is 28 years, you will have your 70% success.
My concern was 4 versus 2 months. 2 months are not going to. You said it was after 4 months. So this is just opinion. Why not wait for 2 more months?
For ART specialists who are doing ART every month, every day is important, Dr. Gujral. We are like this.
The drugs for
our results are not 100%. So the patient is actually looking for positive results. So we are thinking like this. Okay.
And over the period, actually, we have seen that there is not much difference whether we are doing at 4 months or 6 months. both these patients, they perform same way as far as the outcome is concerned, as far as the complications are confirmed. So over the period, we have made this strategy. Previously, we were using 6 months and then starting. Now, 4-month ATT, because we are continuing ATT, preparation requires 1 month. So it completes the 5 months, and when the report comes, it is the 6 months. So, so basically, that is the calculation. That is the calculation.
Please, one more question.
I mean, what should be
question, please. One question for you, Dr. Gujral, again for you. And this is a food for thought for Dr. J.B. Sharma.
Oh my God.
Is there any scoring that we can do to diagnose latent tuberculosis? Is there any scoring? So, Dr. J.B. Sharma, this is for you to develop a score for latent tuberculosis so that it helps all of us. Like Dr. Kuldeep said, you have a lot of patients and experience. So please,
yeah, that's a good idea, man. We can try to develop something. This algorithm is a type of score.
Will have a score or an algorithm. No, score is different from algorithm. You have to have a score.
Okay. We will try to do that. We have been actually trying to do till now.
Specifically for Dr. J.B. Sharma from Dr. Kanchan Rani, how to follow a patient of female genital tuberculosis on ATT and how long? How do you suspect MDR? Because the culture is positive, only a very few cases, and we don't get any reports. Even gene expert is not positive. How do you suspect MDR then? What do you do?
Okay, man. Yeah, you have to give me 2 minutes for that. We actually did a research project funded by Government of India Central TB Division, and in that we had committed that we will do the test again at the end of the 6 months and 9 months. So we 85% we gave them 6 month therapy, 85% we gave them 9 month therapy, and that at the end of the therapy we again did hysteroscopy, laparoscopy, and endometrial sampling on all of them, because we had committed data and we had taken special ethical permission for that. And this actually helped us in a way that at the end of the therapy, almost 45 to 50% patients continue to have positive PCR. So that proved that PCR is to not be done and it's not a sign. But in all of the patients, AFP microscopy culture, though they were positive in 20% less than that, that disappeared. In all of the patients active on laparoscopy, active TB lesions disappeared in all of them. But chronic like adhesions and all persisted. Okay. So that also proved us that, like perihepatic adhesion will probably persist forever. Perihepatic, some other adhesion will persist forever. And on hysteroscopy also, grade 1, grade 2, and to some extent grade 3 adhesion disappeared. But more than that, adhesion persisted. So in spite of ATT. So that was crucial to us. And then, we did, there were 33 patients of TO masses in those patients. Out of those 33 patients, when we completed the ATT, in 8 or 9 patients, madam, TO masses persisted. So those 8 or 9 patients, then we did this PET CT scan. And in those, in 5 patients, PT CTs did not show any glucose uptake. So that means they were just basically fibrotic masses. We didn't give them ATT, okay. But in those 4 patients where the masses were positive and then they had increased glucose uptake, we did FNAC from that. And in about 2 patients, we had suspicion, so we gave them then, at that time this category 2 was also available, so we gave them longer treatment, but there we suspected MDR.
So basically,
in spite of ATT, you have persistent mass.
There will be some patients who will fall into that category.
Yes, madam.
I would advise everybody who's listening to this and seeing what Dr. B.J.P. Sharma is telling us, every patient of tuberculosis is not to be treated by you. Underline, that is the message. Because, every patient is not so simple. If you have these complex problems, let the person who is dealing with so much of tuberculosis deal with it. Yes, just as we have the pulmonologist dealing with tuberculosis, similarly within the gynecologist, we have people like Dr. J.B. Sharma who has a lot of experience. So let them treat the complex cases. Say a patient with IVF, Dr. Kuldeep will treat or Sunita will treat, and if you think I can treat, I will also treat. Similarly, Dr. Kamal Gujral will, and Dr. Malhotra, of course. So basically, what I'm trying to say is everybody should not do everything. That is the message, and we should now learn to, channelize our resources as well as our experience in order that we can treat the patients better. And I think the kind of messages that we are getting from Dr. J.B. Sharma, we have not got from the rest of us because we don't have that kind of experience. He has that experience, and therefore it has to be encouraged, and it has to be recognized. Yeah.
And can I say one more word?
Yes.
And one more thing that we were discussing about whether we should do IVF during a regimen. What should be clear, I think we can keep a balance during intensive phase. 2 months when they are taking RHZT, nothing should be done.
Nothing should
After
be
that,
done.
in continuation phase, that is a
correct.
compromise.
Absolutely.
Okay. But another thing, what I want to highlight: suppose patient falls pregnant.
Yes.
Like patient is in the 3rd month of ATT or 4th month, patient falls pregnant, then many doctors stop ATT. So please don't do that. I want to highlight that in our study, the incidence of abortion is much higher in these patients. Even if they conceive, they are at a high risk of abortion, they are at a high risk of IUD, they are at a high risk of preterm labor and all other complications. So you must continue ATT to them, because ATT will regenerate their endometrium. ATT will increase the blood flow to to the endometrium, and it will increase the chances of pregnancy going to term.
So Dr. Anjali has asked this question, and Dr. Anjali, if you're there, Dr. J.B. Sharma has answered your question. Should it be stopped before completing? No, it should not be stopped if the patient becomes pregnant. And I think what you touched upon is something that Dr. Malhotra did not talk about, especially in the IVF category, where the patient has conceived after long-standing infertility. There, the pregnancies are at more risk for all these complications that you have talked about: abortions, bleeding, preterm labor, everything. So basically, and IUGR, we have to be very careful with these patients. We may lose the pregnancy. Dr. Kamal, you wanted to say something?
No, nothing. No stopping of treatment.
All right, Dr. Mamta Dagar, would you like to make 1 or 2 comments, since you're sitting here right from the beginning with us? Would you like to say 1 or 2 words before we finally call off this whole meeting? Dr. Mamta?
Yeah, I think the academic messages has been very clearly and very aptly been given by all the speakers. I must now just, being the secretary, I must say that the response to this webinar has been humongous. And at the end of the webinar, it's my humble duty to propose vote of thanks to our esteemed moderators, Dr. Kuldeep Jain, and to you, ma'am, Dr. Sonia, ma'am, for organizing this webinar on a very pertinent topic. And my sincere thanks to our vibrant speakers, Dr. J.B. Sharma, Dr. Nandita Palchetkar, Dr. Kamal Gujral, Dr. Sunita Tendulkarkar, Dr. Kuldeep Jain and Dr. Narendra Malhotra for your excellent deliberations and very informative messages. And I'm extremely grateful to our chief guest, Dr. Alpesh Gandhi, for being here today evening with us, for his encouragement, as well as I'm very thankful to our guest of honors, Dr. Parag Biniwale, Dr. Mandakini May, and Dr. Nirja Batla for being with us. And I must say thank you, Ankita, for being here from the beginning till the end, and Sana at the back end. And I must thank everyone at the back end for making this webinar a big success. And it has been really very good. And I think very clearly by all the speakers and moderators, the messages have been very well conveyed to all the members. And I really congratulate everyone for this excellent webinar.
So thank you all, and I think we come to the end of this webinar. Thank you all very much, and it was great, great interaction, and thank you so much for all those.
Thank you, Dr. Sunita Malik, for doing so well, Dr. Sunita and Dr. Kuldeep.
I will just like to thank in the end Bharat Serum for their continuous support for our series. We are having 3 series. This is the 3 topics. This was one, genital tuberculosis. Next one is on endometriosis on 26 July. And 3rd one is on recurrent pregnancy failure, because these are again areas where there is a lot of dilemmas, lot of controversies. And at the end, if we are able to convey some of the take-home messages, then it will be worth attending these series. So with that, I will like to thank again everyone. Dr. Sonia, you have been really wonderful. Basically, without you, it was not possible. So thanks, Dr. Kamal, Dr. JB, and all my faculty. They have really actually given very clear-cut messages. And finally, our host, Ankita, she is actually done wonderful job. She has been doing for last 2 days, just trying to put everything together, and it was really fantastic to have her. Dr. Mala Srivastav and Dr. Mamta, thank you very much for providing us the AOGD platform. It is really wonderful to be a member of Delhi Society. Thank you so much, and thank you everyone who have attended this webinar. Thanks. We will see you again on 26th. Thank you very much.
Everybody.
Bye-bye.
And please
Thank
don't
you. Just a last thing, doctor. We closed
Yeah.
at 922, which was a wonderful count,
Very
being a
good, very
Sunday,
good.
and that too 5 to 6 webinars in a room. So it was really
Yes.
very nice number.
Thank you.
Thank you very much.
Thank
God bless you all, and we will meet again in another forum. Thank you so
Yeah.
much.
Bye-bye.
Thank you so much.
Bye. Bye-bye all.